Yes, we are live now, ma'am. Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar organized by TNFOG, FOGSI No to VAW Committee, and FOGSI Adolescent Health Committee with MOX Endocrinology Committee. It's my pleasure to introduce Dr. Jairani ma'am. Ma'am is the Senior Consultant of Reproductive Medicine and Director of Akash Fertility Center and Hospital. Ma'am is also the past President of FOGSI and Joint Secretary of TNFOG. I welcome you, ma'am, and I hand over the session to you.
Thank you, Sahiti. Good evening, respected Chief Guest, Guest of Honor, and the senior faculties, FOGSI Office Bearers, Jaideep President Sir, Dr. Jaideep Tang Sir, Madam Madhuri Madam, and my own TNFOG President Dr. Ramani Devi Madam, Secretary Sampath, and No to Work Committee Chairperson Dr. Kiran Mai, and Adolescent Health Committee Dr. Supriya Jaiswal, and the senior faculties and my dear friends. It gives me a great pleasure and honor to welcome you all for this webinar, which is a very special webinar, which is connecting our TNFOG with the FOGSI No to Work Committee and FOGSI Adolescent Health Committee on a very important aspects of connecting the adolescent health with all the violence, about the cyber violence, and also about the endocrinological facts about the PCOS. And we are here with a lot of good academics, with the senior people here to talk on this. I have the great pleasure to welcome you all for this webinar. Without wasting much time, we'll start the session with a Tamil Thai. Next, we move on to the traditional lighting of Kuttuvilakku. So now we are moving on to the very important function of this webinar, the inaugural function. I have the great pleasure and honor to welcome and invite Dr. Kiranmai Devyani, the chairperson of the FOGSI No to Work Committee 2020-25, who is the vice president of Hyderabad Society between 24 and 25, a core member of FOGSI No to Work Cell, and the core member and coordinator, TOT, and the faculty FOGSI DIRA initiative, Stop Violence Against Women person, who is a very active, dynamic person for the No to Work Committee. And she's very scientific person also, with a scientific vice chairperson of the ASCOG 2024 in Hyderabad, organized very many international and national conferences in Hyderabad under her dynamic secretaryship, and also had been the coordinating editor for Jogi 2024, And she has been conducting a lot of training program in the UNICEF gender-based violence training on survivor-centered engagement skill. And she has been awardee of so Era Award 2021 and recipient of the MS Signature Award. And she has got the Best Doctor Award from the Government of Telangana for her NCH care in 2023 and the Women Achiever Award by the Government of Telangana. And she has been the trainer of so many training programs and contributed a lot of work on the high-risk pregnancy protocols of Telangana state. We welcome you, Kiran Mai.
Thank you.
Yeah.
Thank you. Actually, I'm traveling, Jaya, and thank you so much for this wonderful bringing up together the TNFOG, AMOX, and both committees, Adolescent Health Committee and No to War Committee. My regards to all the dignitaries here. I could see Kiran Kutkoti, sir, Dr. Sneha, everybody else, the President FOGSI, Jaideep Tank, sir, Madhuri Patel, madam. I think I hope I'm clear because I'm traveling and there is internet connectivity issues.
You're perfect. You're perfect, Kiran.
Yeah.
So, Kiran, can you introduce chief guest? I think.
Hello.
I think your signal is lost, I believe. Okay. Okay, let me have the pleasure to invite and introduce Dr. Supriya Jaiswal, the young and dynamic chairperson of the Adolescent Health Committee, FOGSI 2325, who is the vice president of the Patna OBGYN Society. And she's been the co-trainer for the HPV project E-Zone, joint secretary of Patna Menopause Society and AGOA Bihar and FOGSI Bihar and Jharkhand. She has been an executive member of ISOR and recipient of so many awards and certificates. And she had a lot of publications under her and her special interest in high risk and pregnancy and preventive oncology. It is very nice to have you and Kiran joining together for the Join to Learn series, which is very popular among our FOGSI group. And I'm very happy to be a part of it. We welcome you, Supriya Jaiswal, to carry over the inaugural functions to introduce all the chief guests and the guest of honor. Over to you, Supriya.
Thank you very much, Dr. Jairani, for the generous introduction. And very good evening and warm welcome to all of you, everyone present here. I'm so happy that this series of the Join to Learn series that we started, myself and No to Wow committee with Dr. Kiran Mai as chairperson, we had almost 10 episodes. And during Dr. Rishikesh Pai as president and now continuing as Dr. Jaideep Tank, still it is going on. So it's lovely to have this series. We have had many faculties and very happy to have today as under the FOGSI office bearer, Dr. Jaideep Tank, Dr. Madhuri Patel, Madam, Dr. Kiran and myself are there. Then we have got our TNFOG office bearers, very respected Dr. T. Ramani Devi, Madam, President TNFOG, and Dr. S. Sampat Kumari, Madam, as the Secretary, and Treasurer, Dr. N. Sarvana Kumar. Then chief guest, I am very happy to have Dr. Kiran Kutkoti sir because we had lots of interaction in webinars during the last 2 years. President AMOX and as guest of honor, we have as a guest of honor all Madam T. Ramani Devi and Rakhi Singh, Amia Purendre, all good friends. Dr. Rakhi, real good friend of mine. And thank you, these organizers, Dr. Jairani, Dr. Aruna Suman, and Dr. Nibha Mohan, who is the treasurer, and she is also the secretary of Patna OBGY Society this year. And we have lots of chairperson and other faculties here. So I would really like to, first of all, introduce the chief guest. So we are really blessed to have you, Dr. Kiran Kutkoti, sir, as President IMOX, as a chief guest today. I'm very, very happy to have you. You are the ex-chairperson MTP committee and you're lots of...
That's fine.
Yes,
that's fine.
we know you. Okay, over to you for your words of blessings.
Yeah, thank you. Thank you. At the outset, a very warm welcome on behalf of AMOX to all of you. And, really three big organizations. FOGSI, of course, is our parent organization with Jaideep and Madhuri at the helm. And of course, TNFOG with respected Dr. Ramani Devi there. And Dr. of course, Sampath Kumari and Dr. Sarvana Kumar of TNFOG. And Dr. Kiran Mai, the chairperson of the No to VAW committee, Dr. Supriya, the chairperson of the Adolescent committee. Today's guest of honors, Dr. Ramani Devi, Rakhi ji, Dr. Ameya Purandare, Vice President of AMOX. A very warm welcome to all of you. When this particular committee was formed, I think 3 to 4 years back, I think by Dr. Shanta, we were really wondering what exactly is this committee going to do. But as the years have passed, as the months have passed, we know what the volume of work that this committee can do and is doing. So I must really appreciate the first chairperson and of course the current chairperson of the No to VAW committee. Really hats off to you, because to think of topics or to bring out topics which are really of concern, because initially what we think is violence against women, gynecologist ko kya sikhayenge? Okay. But that is the thought process, that as a thought process, as a male gynecologist, I thought ki humko kya sikhane wale violence against women? We don't do any violence against women. But the thought process behind the thought process of Shanta behind starting this particular committee, today you realize how important it is. Today you realize how important that has in today's context. So really hats off to her vision, and really you're doing excellent work, and we really look forward. And when Dr. Jairani calls, you can't refuse. When she calls that you have to be a chairperson or a chief guest or whatever capacity that you want, you just cannot refuse, because such is the stature of Dr. Jairani, and such is the affection that is shown by her to all the Amoxians. So thank you so much. Supriya ji, what can I be said about you? We have always been good coordinators and collaborators in whatever activities that you're doing. And I hope, wish and pray that all the chairpersons of FOGSI include as many Amoxians in their webinars or in their committees as much as possible. Now, AMOX will be holding its conference in Chandrapur. So on the Valentine Day, that is on 14th of February, 14, 15, and 16. So I welcome all of you for the Chandrapur conference, and those of you who wish to be the faculty members of that conference may ping WhatsApp to me in my individual capacity, or to Supriya also, or to Dr. Ameya Purandare also, and we will be most helpful and most accommodative to all of you as faculty members. Having said this, I really look forward to what Dr. Kundan and Dr. Ganeshan sir, and of course Dr. Supriya and Nibhaji will be saying in the rest of the webinar. My best wishes to all of you. My best wishes to Nibhaji also in
Thank you, sir.
in FOGSI. I would welcome Dr. Ramani Devi, that whenever we are having a conference in Pune, Dr. Ramani Devi, you will be there as far as I am concerned. So most welcome, and Arunaji, you also. Thank you, Rakhi. Rakhi, best wishes to you also for your FOGSI endeavors. Thank you so much.
Kiran sir, thank you. Kiran bhai here. Thank you so much. I lost connection in between. Thank you for all your kind words and your encouragement and blessings, sir. Thank you for joining today.
There are a lot of Kirans today. I think Kundan, you have to rename yourself as Kundan.
Yes.
You have said it is Kundan.
You have written Kiran Ingle.
Kiran Ingle. You have to rename yourself as Kundan.
Done.
Yes, thank you. Hello, Kundan. Yes.
Yeah, and one more thing I must really appreciate is the prayer that you showed. I mean, really touched our hearts. I don't understand anything about Tamil, but the way you projected Valluvar's statue, thanks a lot for that. Really had a marvelous time.
It's a Tamil.
I know.
It's a wish from the Tamil, sir. It is for the Tamil which we patronize as a god.
So thank you so much, Kiran sir.
For a lovely word, sir. Thank you, sir.
Thank you.
Yes, and really you have encouraged everyone, and that the prayer was really very good, very good. So thank you, sir. Thank you. And moving ahead, we have as guest of honor, we have Madam T. Ramani Devi. So Madam is President TNFOG and National Vice President FOGSI 2020, International Advisory Board Member of Athletic Society of Bangladesh, Madam had been the ICOG Governing Council
Supriya,
member.
I think don't waste time, Supriya.
Okay,
It
Madam is
Yeah.
has many accolades to her credit, and we are very happy to have you as a guest of honor. Over to you, Madam, for your words of blessings.
Thank you, Supriya, for your nice words. First of all, I should congratulate Jairani as well as the Adolescent Committee and the FOGSI No to Violence Committee, because it's the Triveni Sangamam, I should say, along with AMOX Endocrinology Committee. We are having this program today, and it has been planned very well. I think the topics based on the endocrinology, you have got the precocious puberty as a topic. That is excellent, because everybody has to understand about it, because it's a one problem which can be treated very easily. Then the next program is having this is that internet and cyber violence that is on the increase. And we have a great speaker, Dr. V. Ganesan, who's going to give a talk about how we can escape all these types of violence. And again, the most important topic is PCOS and adolescent. I should say this is a burning one, because right from the adolescent age, we have to cut short the progression of the disease, so that the young girls will have a very good life. And then I think I should thank Dr. Kiran Kuttikodi for having involved me in all the programs of Pune, and I would be very happy to be there. And I wish Dr. Raki Singh, Dr. Jairani Kamaraj, Dr. Aruna Suman, and Dr. Niba Mohan in their future endeavors. I think we have a long list of faculties and the chairperson. With this, I end, and I wish the program a grand success. And Jairani and others, you should achieve whatever you aim in your life. This is my wish. And I pray God that all your wishes will be fulfilled. And thanks for the opportunity given.
Thank you, Ramani ma'am. Thank you so much.
For your wishes. Thank you, ma'am.
Thank you, ma'am. Thank you for the wonderful words and very impressive, very powerful words of blessings to all of us.
Thank you.
Dr. Amya Purandare, the next guest of honor. We have a very active consultant obstetrician and gynecologist, Purandare Hospital, KGS Omaya Medical College, Senior Vice President AMOX, Joint Secretary.
Supriya ji, thank you so much.
Yeah, I know. So we are very happy to have you, and we want a few words of good wishes from you.
Yeah, it gives me great pleasure to be here this evening. As you must be aware, all of us in Mumbai are working very hard for the AICOG 2025. I'm just back from one meeting and then again going to the venue for another meeting. So it is going to be a grand spectacle, and I wish all of you to please come and attend, and we are all here to welcome you. I would like to thank Dr. Jairani for extending this invitation, Dr. Supriya, Dr. Kiranmai, Senior Dr. Sampat Kumari, Dr. Ramni Devi, my colleague and Senior President, Dr. Kiran Kurtakoti of AMOGS, the AMOGS Endocrinology Committee as well, and my dear friends, Dr. Rakhi and Dr. Nibha, for being a part of this program. As you know that this program is mainly centered under the FOGSI violence against women and the endocrinological aspects. I'm really happy to see that the most esteemed faculty are going to be delivering important talks on various key issues. So once again, I would like to congratulate all the organizers. I would like to congratulate all the member societies who have come on a united front for this very important webinar. It's called aptly the Join to Learn series. So I think all of us are joining together to increase the knowledge of our members. On behalf of AMOGS, like Kiran said, that we are looking forward to welcoming you in Chandrapur, which is the tiger capital of Maharashtra, and that the association between AMOGS and all the regional societies continue and become even more stronger in the years to come. So thank you so much. I'm sorry I have to leave because I have to go for the next meeting of AICOG 2025.
Thank
All the
you.
best for your all the efforts for
Thank
AICOG.
you, Dr. Amaya. We are looking forward to coming to Mumbai and experience all the grandeur. All the best wishes.
Thank you.
Thank you, Dr. Amya. Thank you for joining still in spite of your all busy routine. So thank you so much. Thank you. So we come to Dr. Rakhi Singh, the next guest of honor of today. She is the president of Noida Society, governing council member of ICOG, vice chairperson of UP State SR, peer reviewer for journal and obstetric and gynecology, that is Jogi, chairperson of endocrinology committee FOGSI, where she worked lots and lots. She had really done wonderful programs during her tenure, and she is the proud recipient of so many awards and achievements and publications. Then this you can see, and she's also the director of Avalon Clinic Maternity and Fertility Center, IVF Center, the Sector 41, Noida. So over to you, Dr. Rakhi. Although I know you have a bad throat, but still we would like to hear from you.
Sorry for my bad throat, but I will keep it very crisp and small. I congratulate Tamil Nadu societies, NFOG, FOGSI, and Violence Against Women, which is being led by Dr. Kiran May. And it is something which is very, very, very important for all of us to be addressed and understand it and move ahead with that. And understanding of VAW is very important, and it is very nicely, aptly taken up by the adolescent committee, because all the violences start at that level, and the topics chosen are really good, with the precocious puberty and the topic being the internet and the cyber violence, which increases at length. And I congratulate Dr. Ramani Devi ma'am, who is the president of TNFOG, and Dr. Sampat Kumari ma'am, Dr. Jairani, and Nibha. Thank you, Kurti sir, for addressing, and thank you for being there. And he's such a lovely person who's there for everybody. And Aruna Suman, my dear friend, this time best wishes. I would like to see you rising up. And Nibha, also all the best. And
Thank you, Rakhi.
Thank you, Dr. Rakhi. I think your throat is not well.
Apologies.
Thank you so much for joining. Yeah. Thank you so much.
All the best to Rakhi. For you also, all the best.
Get well soon, Rakhi ma'am. Rakhi ma'am, get well soon. All the best.
Good evening,
you,
Sampat
Rakhi.
ma'am. Good evening, Supriya.
Good evening, Kiran Mai.
Supriya Square.
Yes. So thank you so much, Dr. Rakhi, and all the best from you to Jairani, Supriya, Aruna Suman. Actually, we are really wish you all the best.
Thank you so much,
Dr. Nibha Mohan,
Rakhi.
our own Dr. Nibha Mohan. So all of
Thank
you do
you.
your best. We are there with you, and do your best. And over to you, Dr. Jairani, to carry forward.
Thank you so much. Thank you, Kiran sir, for being with us in midst of your busy schedule. Gracing, whenever I called you, you were there. Thank you for your support and kindness. Amaya, I know you are very busy, but still you have the time to join us. Thank you so much. And Rakhi, in midst of your ailment, you were there kind enough to talk in this webinar. Thank you so much. A very special thanks to Ramani madam and Sampat for giving me this, our TNFOG, to work for this committee. Thank you so much. I thank all the chief guests as well as the senior faculties. Now we'll move on to the academics. I have the great pleasure.
All the best, Jairani.
Priya, put it in a silent mode. So we are moving to the academic session. I have the great pleasure and honor to welcome my dear friend, Dr. Aruna Suman, who is a professor of OBGYN and HOD of the Government Medical College, Telangana. She's the Joint Secretary of the FOGSI 2021, and she has been the Organizing Secretary of the ACOG Hyderabad in 2024. And she is the National Coordinator of the No to Work Committee and the Practical Obstetric Committee FOGSI member in 24-25. And she has been the South Zone Coordinator for the FOGSI 22-23. And she was the Vice President and Treasurer of Hyderabad Society in 2023. And she has been training for so many training activities.
Thank you, Dr.
And,
Jairani.
we
I
are
was
very
an
anxious,
adolescent
looking
health
forward, very
committee
nice.
FOGSI member too from 2016 to 18 under Sampath Kumari ma'am. Thank you so much. That was my privilege.
Thank you. Over to you.
Thank you for the nice words. Yeah.
Yeah. Carry on with the first session. Yeah.
Yes. Okay. I'm very happy to introduce Dr. Amruta Parag. She's practicing as consultant at a multi-speciality hospital at Kumtekar, Solapur since 15 years. Academic achievements, MRCOG Part 3, she has completed in December 2018 in first attempt. MS from KEM Hospital, Mumbai, second rank in Mumbai University, gold medal in FCPS examination, assistant professor at KEM Hospital, Mumbai, 2 years, co-authored articles in National Journal, FOGSI Focus, worked as clinical secretary of Solapur OBGY Society 20 to 25. I welcome you, Dr. Amruta. And it's my pleasure to invite Dr. Rashmi Keher, Chairperson-elect, FOGSI Practical Obstetric Committee 25-27, President Amravati OBG Society 24-25.
Thank you, Aruna madam. Thank you so much.
Chairperson, let me
Thank you,
introduce you,
dear ma'am.
Rashmi. Thank you.
Thank you, ma'am.
And I
Thank you
welcome
so
you,
much,
Dr.
ma'am.
Rashmi.
Thank you, ma'am.
And the next chairperson is Rujita. She runs a cancer screening, cervical cancer screening and colposcopy clinic at Nagpur. She training colposcopy at CNCI Kolkata, fetal medicine at BFMC Bangalore, and fellow of Indian ICOG maternal Indian. Yes, achievements are late Dr. Rangilal Singh Memorial Award, Dr. Sundari Pai Kunabar Memorial Award, Dhanvantari Award, and late Srimati Shakuntala Suryavanshi Memorial Award, Pfizer Gold Medal for Excellence of Undergraduate Studies. Delivered prestigious Yuva Knox Oration in 2015. Editor-in-chief of a book on menopause and chapter contribution in 4 books in OBGY. Presentations, original research article publication 9 as first author and 1 as second author in international journals, faculty at local and regional national conferences, and she's having many awards and accolades. I welcome you, Dr. Rujita. And please introduce the experts. I welcome all the chairpersons to introduce the experts as well as the speaker.
Over to the chairpersons, Rashmi.
Dr. Rashmi,
Yes.
please introduce Dr. Sneha Buyar.
Yes, ma'am. Dr. Sneha Buyar, a personality who really needs no introduction. Madam is AMOX chairperson of Emergency Obstetric Committee and National Adolescent Trainer. She with 29 years of experience in the field in teach and also in teaching and practice. She has been working at the Government Medical College of Yavatmal. We all know as a person of highest academic excellence, and it's a great honor to welcome you, dear Sneha ma'am.
Thank you. Thank you so much.
Our next expert is Dr. Sangeeta Wagh. She is president of Nashik OBGYN Society and director at Usha Hospital of Nashik and has been practicing since last 27 years. Heartiest welcome to Dr. Sangeeta Wagh, madam. And it's a great honor to introduce our speaker today, Dr. Kundan English sir. He will be talking on precocious pregnancy. At present, he is HOD Vishwaraj IVF Center, Hadaspur, Pune, and chairperson of AMOX Endocrinology Committee. He had been chairperson of Infertility Committee of FOGSI in 2020 to 23 and a managing council member of ISAR. He is director of Nirmiti Clinic, which is a center for assisted reproduction and endoscopy at Pune. And at present, he is vice president of FOX, and he has been working as founder treasurer of Maharashtra chapter of ISAR 2011 to 2014. It's a great honor to welcome you, sir, and we are really eager to listen to your talk.
Thank you very much for those kind words of introduction. I'm just trying to share first the slide. And all right. So do you see my slides?
Yes, sir. Yes, sir.
Yeah. Thank you. Thank you very much for those kind words of introduction. Thank you, Dr. Jairani, for those for those all invitations you have been, blessing to me for attending so many programs. And this is one of the program which you have associated with AMOG's Endocrinology Committee. Thank you very much, and all the organizers, all the organizing team. All the best for your future endeavors. And today I'm going to speak on precocious puberty. And let me tell you some from basic to advanced management, because we know that we do see patients not on very rare basis, but we do see them intermittently. But I think the more anxiety is related to the parents rather than that young girl. And as a clinician, first of all, we need to understand this subject very well. And we'll begin with the definition that puberty that begins much earlier than usual. This is the simplest way we can put it, but it is something like defined as appearance of secondary sexual characteristic before age 8 in the children assign children assigned female at birth. Means for the females, if the onset is before 8 years, and for the boys, if the onset is before 9 years, that is called precocious puberty. Now, it is nothing but early activation of hypothalamic pituitary gonadal axis, and it is manifested by breast development in girls or testicular enlargement in boys before the normal physiological age ranges. And I must tell you, this normal physiological age range for girls, it is from 8 to 13, and for the boys, it is 9 to 14. And if it is before that, then this is called precocious puberty. Now, to understand, according to the etiology, this particular disease is classified into three categories rather. One is a central precocious puberty, and which is always called as gonadotropin dependent. It basically results from premature activation of hypothalamic pituitary gonadal axis, and this is something which is more common in girls than boys, almost 15 times. This is what you will see when you see a young girl. Now, a peripheral is something which is gonadotropin independent, so it's not dependent on gonadotropins, or it is also called as a peripheral precocity, and it is nothing but it is due to the production of sex steroids from endogenous or exogenous sources. So either it is from coming from inside or from outside. And there is a third category which is called incomplete precocious puberty, where there is a premature thelargy, that is a breast development, but there is no adenarche. And the second presentation you will see is a premature adenarche, that is more like a puberty hair development without any much other secondary sexual characteristic. So these are like isolated findings, but we need to observe them closely because they may land up in a precocious puberty very soon. Now, coming to etiology, when it comes to central precocious puberty, it is we need to understand that 75 to 80% you are not going to get any reason. So it's going to be idiopathic. Okay. So rest of the 25-30% patients, you will see some kind of abnormality in the CNS. Majorly, one of the most common which we see in CNS tumors is hypothalamic hamartoma, or you may have any other benign tumors like optic glioma, arachnoid cyst, astrocytoma, or ependymoma, hydrocephalus, septo-optic dysplasia, or pineal tumors. So they can lead to central precocious puberty. You may have a central nervous system injury in form of head trauma, cranial irradiation, cerebral palsy, or infections like tuberculous meningitis. Another which is very commonly seen is nowadays, because with the help of newer sequencing, that we started diagnosing a lot of these idiopathic cases having actually genetic origin, and there is a loss of function mutation encoding the MRF3 gene, and that is what is known as MKRN3, or gain of a function mutation encoding the KISS peptide, that is KISS1, or its receptor gene, that is KISS1R mutation. So these mutations, now we can diagnose them with exon sequencing, or newer methods of genetic testing, and now we started seeing a lot of patients are having genetic origin for central precocious puberty. There are certain syndromes like neurofibromatosis, Sturge-Weber syndrome, or tuberous sclerosis. They are also known for central initiation of central precocious puberty. There are people, it has been associated with, more commonly seen in adopted children or those who have withdrawal from the sex steroid therapy. There is also one entity called familial precocious puberty, typically seen in boys mainly. So it is called as familial boys limited precocious puberty. We are going to understand this. But there is something called as a hypothalamic hamartoma, which I want to say because that's commonly seen when it comes to a non-idiopathic group. And it's nothing but there are ectopic neural cells in the lesion, which is serve as a accessory GnRH pulse generator. So these ectopic neural cells, they causes kind of GnRH pulse, and that leads to stimulation of pituitary for gonadotropin stimulation, and they are associated with some kind of gelastic seizures for these patients, which are usually not responding to the medication, and also they are associated with some kind of cognitive, behavioral, and psychiatric symptoms in these patients. So that's how an MRI is something which will help you to diagnose this kind of hematoma, as you see it marked with a red arrow. So one of the very common scenario when you try and find out an patient having central precocious puberty and you investigate, this is something which you see commonly. Now when it comes to peripheral, it is little divided according to the source of hormone. So like if it is higher gonadotropins coming from gonads, or sex steroids production from gonads, then it is commonest is McCune-Albright syndrome, or ovarian tumors, or Leydig cell tumors are the one of the very common ones. Then if the sources of androgens are from adrenals are very high, like congenital virilizing adrenal hyperplasia or adrenal functional adenoma or carcinoma, those are the reasons in adrenal category. You have SCG producing tumors also, like chorioepithelioma, dysgerminoma, teratoma, or choriocarcinoma, or hepatoma and teratoma. So these are they will produce SCG, and we know SCG acts like LH, and it can stimulate production of androgens as well as estrogen. Now others which are primary hypothyroidism or iatrogenic because of long standing hypothyroidism, it may cause central precocious puberty. And as we discuss about normal variant puberties like premature thelargia, premature adrenarche, you find them as an isolated finding without any systemic disease. So when you see such patients presenting to you, they are coming with their parents, and very anxious parents comes to us with these symptoms. So we have to ask these questions to ourselves when we are handling precocious puberty. The first thing is that, is the precocious puberty is a normal variant, or it is actually abnormal sign? And this is how you have to assess the secondary sexual characteristics and ask them a leading questions like, does she have any kind of pervaginal bleeding also? Has she noticed that? So all those questions, and we have to differentiate first whether it is variant or it is really a precocious puberty. If it is precocious puberty, then we have to categorize whether it is central or peripheral. And if it is peripheral, is it adrenal or gonadal, as we have seen the etiology. If it is central, then is it a idiopathic or related to some kind of intracranial pathology? Is there any indication for treatment? So this, if you answer this question, you will start finding your cause, etiology for precocious puberty, as well as management for the same. Now when you are evaluating, this is how you will ask the questions: at what age of onset? And now that is very important, that age of onset is very important, because the more earlier you see, if you would have started kind of treatment little early, there is a good chance of achieving the height for that girl, and that's why that age of onset is very important. Also the time of onset of puberty in mother as well as siblings for a familial condition to happen. Is there any history of neurological disease, trauma, infections, or is there any exogenous sex steroid therapy, maybe through food, maybe through facial creams or drugs, and kind of a social history like child sexual abuse or international adoption? All those points are very important. When it comes to physical examination, first you check the height of the patient, weight, then you calculate BMI and you check the growth velocity. Then go for your Tanner staging to assess that how much secondary sexual characters have been established. Then you look for those other causes for like examination of skin for the capilla spots, abdominal examination for mass, or go for eye examination, fundoscopy, visual fields, neurological examination, signs of virilization, and then you can go for selective investigation. The most important investigations are going to be basal gonadotropins level first, then comes GnRH stimulation test. Also check estradiol or testosterone level according to the gender, and then according to the division of category, then you can selectively go for adrenal steroids or ACTS stimulation test. You must check for free thyroxine, that is free T4 and TSH level in these patients, and also serum prolactin, which are raised in prolactinoma and hypothyroidism. When it comes to imaging, the most important, don't forget to see the X-ray of the left wrist for the bone age. And if the bone age is advanced, also one of the very important factor in diagnosis and evaluation, and for the prognosis assessment or prediction of the height achievement during the therapy. Also for searching the reasons for central nervous system, CT or MRI brain, for the adrenal tumors for CT, and a pelvic ultrasound for any ovarian masses. So these are the investigations. So we need to understand about the most important test, because see, we are going to handle these precocious puberty girls. They are more commonly we see idiopathic. So what we need to do is a GnRH stimulation test for these patients. That's the first thing which we must do. Now, if LH levels are measured, which are typically measured in the morning hours, we have to measure it 50 to 60 minutes after GnRH stimulation. So typically 30 minutes from GnRH injection, maybe after GnRH stimulation, or you give GnRH analog administration, and then 30 minutes later you check the LH levels, and if they are more than 5 IU per liter, then that is something a positive GnRH stimulation test. Now typically we must first understand what are the basal levels. So when pre-pubertal levels, which are unstimulated levels, usually before puberty, the levels are less than 0.1 units per IU per liter. So that's one thing we have to understand. It is less than 0.1. Okay. Pre-pubertal LH pulse, it can reach to 1.5 to 2 unit IU per liter, whereas a level greater than 4 to 5 IU per liter, that actually suggests that puberty has begun. So just before puberty, you may see a pulses are rising up to 1.5 to 2, but if it is beyond 5, you know that the puberty has established. Okay. Also, what you can do is once you give a GnRH agonist stimulation, then you have to see the peak LH to FSS ratio, which ratio, if it is between 0.6 to 1.0, again, it is one of the important diagnostic tests. But remember, there are three important parameters. You are going to check FSH and LH after GnRH agonist depot, but do not rely on FSH. This is not something which we have to look for. We are calculating FSH only to calculate this LS FSH ratio. But look for typical the single LH level at 30 minutes after the depot injection. And if it is more than 5, your puberty establishment diagnosis is clear. Then we know that when you are handling these girls, the central precocious puberty is more common than peripheral. So go for either MRI or CT of brain after the neurological examination. You can also look for ultrasound abdomen for other abdominal tumors. Go for X-ray of the left wrist to assess the bone age. So three things to be once the diagnosis of puberty is confirmed. Also remember, if there are high estrogen levels with low gonadotropins, it always points out to the peripheral precocious puberty. Remember, high estrogen levels with low gonadotropins, it is gonadotropin independent, that is called peripheral precocious puberty. And yes, we must know, we must advise thyroid function test to rule out pseudo precocious puberty due to long-standing hypothyroidism. This is one of the good chart which I found out. So one of the chart which says that once you see the early breast development in girls, we look for another pubertal signs, and if they are normal, you check the growth velocity by the bone age, and if it is still normal, or if it is chronological age is less than 2 years, then it is called as a infantile premature thelarchy. If the chronological age is more than 2 years, we have to look for prepubertal pelvic ultrasound, and also we have to find out whether FSH is more increased or increase FSH cellular response to the gonadotropins, which can lead to premature thelarchy, and only follow-up is necessary. Now, if you see a advanced age, which happens with these precocious puberty girls, then you go for a pubertal pelvic ultrasound, okay, and that ultrasound will help you after you checking out the LH response to gonadotropins releasing hormone. Okay, so when you see increased LH levels in response to gonadotropins, or also having high circulatory LH levels without any stimulation, then you look for CNS imaging, whether they are normal or abnormal. If it is normal, then it is called as central precocious puberty with idiopathic cause, and you have to consult an involved pediatrician, endocrinologist, and the treatment is GnRH agonist treatment. If it is an abnormal CNS imaging, then probably you have to see for those etiology and treat accordingly, with the help of neurosurgeons or neurophysicians, like the tumors, which is most common in this area. Now, suppose you have a low FSH and LH level, or there is a decrease or low LH and FSH respond to GnRH agonist. It is called as peripheral precocious puberty, where you look for ovarian evaluation, look for ovarian cyst, or look for any history points of whether she's on any steroid therapy. Look for cafe au lait spots, because if they are positive, it is McCune-Albright syndrome, and then you have to consult pediatric endocrinology and sometimes aromatase inhibitors for such kind of patients. So that's another good flow chart, which is you can follow it. And what is the impact of precocious puberty? Why we are so worried, or why should we treat them? So remember, there is a high chances of shortening the achievement of shortening of the height due to early epiphyseal fusion. Patient may face behavioral disorders, increased risk of metabolic syndrome in her life. There is a early initiation of sexual life because of the increased risk of unwanted, and there is a consequence leads to increased risk of unwanted pregnancy. There is an increased desire for sexual activity. The social impact is, again, we have to remember, because they are prone for potential sexual abuse, because they start looking more adult girls, and that's what is the problem, and they may face a kind of abuse in terms of physical violence. And we have to understand the importance of, and counsel the patient as well as the parents. When we are treating, we have to have two goals. The first is to preserve the adult height, so we try and treat them so that we try and achieve that adult height which she would have achieved it anyway. And to second is to elevate the associated psychosocial stress. So workup is important, history and clinical presentation is important. Go for physical examination, check the gonadotropins level, check the gonadotropins level according to the GnRH depot administration. Go for radiological imaging investigation, TSH is must, and then lastly you go for genetics if you ruled out any other causes. Now, when you're treating central precocious puberty, especially as I mentioned, you give GnRH agonist depot, because it blocks the GnRH receptors on the pituitary, and it doesn't allow pituitary to release FSH and LH. So there is not going to be any overhead steroid production, sex steroid production. So that is going to cause a kind of a very low hypoestrogenemia, and that is going to help us to achieve or prevent the shortening of the height. So how do you give it? You use 11.75 milligram of GnRH agonist depot. Every 3 months you're going to give. Now, periodic monitoring is very important, that you see the pubertal progression, whether if your agonist is working, you should not see any pubertal changes progression. Whether growth velocity is also important, that whether you are achieving the growth velocity as per the expectations, and skeletal maturation are these are all very importantly are necessary. Choice of route is most commonly intramuscular. Intranasal is one option is available, but we use more oftenly intramuscular injections. Now, what is something which you have to monitor? So you monitor with the LH levels 30 to 60 minutes after giving depot GnRH agonist, and that you can use as a to monitor therapy. So levels of LH opt-in should not cross the pubertal value of 4 to 5. Try and maintain the LH level between 2.5 to 4.5 IU per liter. So that should be your goal, and that you can consider that your GnRH agonist is acting well. So after injection of every 3 months, you can check these levels. Expect some per-vaginal bleeding in some patients after GnRH agonist injection, especially in the initial time period, 1 or 2 initial doses. So please counsel the parents that they might expect, otherwise they will, raise the alarm and red signal, and they rush to the hospital with that complaint. Now, how long it is very important, because we know what to give, but how long we should give. So treatment can continue till pubertal or chronological ages are appropriately matched, or until the epiphyses have fused. So you monitor the therapy by doing a sequential radiological imaging of left wrist, and find out and achieve bone age you assess, and according to that, once the bone age is achieved, or you have a pubertal and chronological age, so it is typically this is discontinued by 10 to 11 years. That is the time period. So if you have started say that 7 years, then 3 years, at least 3 to 4 years. If you have started before 6 years, the even therapy keep going on for 5 years, because we must understand that menses usually occur by 9 to 20 months after stopping the treatment. So if you stop it at 11 years, she might get her menses in 13-year age, which is a correct age for her expected menarche. So, typically keep it in mind that at least up to 10 to 11 years you have to give, but of course you have to also monitor the bone age. Now, what are the impact of GnRH agonist? We are giving it for a long term. So what impact which we will get it on the height? So with therapy, as much as 9.8 centimeter gain in the height has been reported in trials. So close to 10 centimeter more gain we will be achieved with the use of GnRH agonist. So it's a good impact, it's a positive impact, beneficial impact. What is the impact of therapy on reproductive function? So we need to understand that after discontinuation of GnRH agonist treatment, there are levels of estradiol and gonadotropin's pulsatility frequency comes back to normal as it is really early, as early as by 9 to 20 months. So there is no difficulty these girls are going to face it for natural conception or any adverse pregnancy outcomes in treated patients in future life. So you have to reassure parents that though we have given GnRH agonist for a longer time, do not worry, her reproductive function will not get affected because of the long-term therapy of GnRH agonist. And what are those factors which will affect the outcome of therapy? So advancement of bone change. So remember, if at the initiation of the therapy, if the bone age is already advanced, you will not see that 10 centimeter increment into the height with your therapy. So assess the bone age at the initiation so that you can predict what kind of height you can achieve. Or age at which precocious puberty is initiated. It has been documented that if the precocious puberty is less than 6 years, means happened at age which is less than 6 years, and if you have started in a therapy even earliest less than 6 years, you can achieve a good impact of therapy in these patients, like achieving that height of proper of 9.8 to 10 centimeter as reported by literature. Even the timing of initiation and duration of treatment is very important. The more wider the duration of treatment, the more better achievement of the height. What about peripheral precocious puberty? So typically peripheral is typically from adrenal tumors or gonadal tumors. So you treat them by surgical if they are surgical problems or surgical tumors. You can stop the source of exogenous steroids, like if she's on some kind of food or if she's applying some kind of cream, you have to stop that therapies. We know that if there is a classic congenital adrenal hyperplasia, you have to treat them with glucocorticoids. If it is McCune-Albright syndrome, you have to block the estrogen synthesis by using aromatase inhibitors like anastrozole or letrozole. And also you can use selective estrogen receptor modulator, which are tamoxifen in these patients. So McCune-Albright syndrome is the one area where you will use letrozole or you will use a tamoxifen. As I said, there is In boys, typically you see this familial male-limited precocious puberty. In these boys, you can give spironolactone 5.75 milligram per kg per day as a starting dose, and then you can increase up to 500 milligram per day combined with anastrozole 1 milligram per day to stop that adrenal production in those patients. Now, as I said, in incomplete precocious puberty, usually that is isolated, that is precocious thelargy or precocious puberty. So, thelargy and adrenergy. Usually, you do not require any treatment as they are considered to be normal variants of early pubertal growth, and you just have to closely follow up this patient because few of them may develop as a complete precocious puberty. So, once you see this isolated thelargy or thelargy or adrenergy, probably you consider as a normal variant and wait and watch. Keep them, ask them, keep visiting every 3 monthly so that too you can diagnose them if they are actually going into complete precocious puberty. So just to summarize, CPP, that is central precocious puberty, is a rare disease. We don't see them very commonly, but they are caused by premature reactivation of HPG axis. Multiple physical and psychological comorbidities are associated with this situation and can be prevented or attenuated by treatment with GnRH analogs. We need to do a broad and comprehensive clinical approach to evaluation. The boys and girls referred to for CPP must be examined thoroughly to confirm the diagnosis and to rule out genetic or complex forms. And GnRH analogs are highly effective treatments to prevent the progression of pubertal changes in patients with central precocious puberty independent of underlying cause. So one of the good therapy GnRH analogs only, and that is something which we see commonly, central precocious puberty. Peripheral is very, very rare, but even if you get peripheral precocious puberty, you evaluate for the tumors, check for the therapies, and you correct them, and that should be enough for them. So thank you very much for the patient hearing, and I hope I could do the justification for the topic which I've given.
Thank you so much, Dr. Kundan Ingle sir. 100% justification to the topic. And thank you so much for adding such a superb clarity to a topic of such complicated pathophysiology. Most of the doubts have been cleared. Thank you. The disease is such a stressful condition, not for the child, but also for the family. And thank you, sir. Each slide was worth taking a screenshot. I have taken. And I would also like to request organizers to give a recording of this talk. And we have our expert, Dr. Sneha Buyar, madam, with us and we would like to listen to her views also. Dr. Sneha, madam, if you are here.
I think she's.
I cannot see Dr. Sneha. Dr. Rashmi?
Okay, ma'am. So thank you, sir. That was really a wonderful talk, and thank you very much.
Thank you. Excellent talk by Dr. Kundan Ingle. And thank you, chairpersons, Dr. Rashmi Kahat. Thank you so much.
Thank
and
you,
moving to the next session. It's my pleasure and privilege to invite Dr. Niba Mohan, a good friend of mine, consultant at Renu Maternity Center, Patna, treasurer, Patna OB-GYN Society, secretary-elect, Patna, joint secretary, clinical secretary. Please let me have the privilege of introducing you. News Bulletin Editor, ISOPAB, Clinical Secretary, SOVSI, Bihar, Jharkhand Chapter, Member, FOGSI Safe Motherhood Committee 2023, East Zone Coordinator, FOGSI Family Planning Welfare Committee, presented many papers in state and national conferences, special interest in safe motherhood, ultrasound, high-risk pregnancy, infertility, MS Signature Awardee 2021, National Trainer FOGSI Manyata Program, Master Trainer for FOGSI HPV Vaccination Program. I welcome you, Dr. Niba Mohan.
Thank you so much, Dr. Rana, for such a beautiful introduction of mine. Thank you. At the outset, I'm really happy to be part of this event, which is jointly organized by TNFOG, FOGSI No to VAW, FOGSI Adolescent Health Committee,
Dr. Niba Mohan, your voice is crackling. It's not clear. Sahiti?
Sahiti,
Yes,
Niba
ma'am.
Mohan is last. I
Yeah,
think
there is
Yes,
some
ma'am.
problem
Ma'am
with
is
the
having
internet.
she has a
connectivity issues.
Okay.
So I think Aruna, can you introduce the other?
Yes, yes. And let me introduce Dr. Sangeeta Tajpuria. She is director of Vedansha Hospital Test Tube Baby, honorary secretary of NOGS. She has got many publications, international publication, original article in Journal of OB/GYN, efficacy of combination therapy of inositols, antioxidants and vitamins in obese and non-obese women with PCOD. Observational study, national publications. She has contributed chapters in FOGSI Focus, Vaccination in Pregnancy, Comprehensive Bulletin in 2011, Prediction and Prevention of PIH, and many chapters she has published, and awards and orations. Guinness Book of World Records holder for largest blister pack mosaic, which measures 950.21 feet. 2 of Shelcal tablets. Received Times Power Women 2222 award. Received Golden Aim Women Healthcare Award. Received RCNV Vocational Services Award. Yuva Knox Award, Best Paper in World Congress on HIV 2008 at Nagpur, delivered Yuva Knox oration. I welcome you, Dr. Sangeeta Tajpuria. I feel happy and it feels wonderful to introduce dear friend.
Niba is
Hello.
here?
Hello, yes.
Yeah, you
Yes,
lost.
yes.
Your internet was
Sorry
lost.
for being disconnected.
You can introduce the next chairpersons.
Yes.
Yeah.
Our next chairperson is Dr. Sandeep Nikade, very well known to everyone, is President Nagpur Obs and Gynae Society, and is member of many important societies. Is winner of IAG Annual Conference Endoscopy Award also, and he's performed more than 15,000 laparoscopic procedures and operative faculty at various national and local live operative workshop. So over to you, both the chairpersons, Dr. Sandeep and Dr. Sangeeta Tejpuriar, to introduce our very special speaker, Dr. V. Ganeshan sir, who is going to speak on internet and cyber violence against adolescent women. And our expert, I don't think she's been introduced.
No, you can introduce
Our
madam.
expert is Mrs. Radhika, senior IPS officer, and she'll be as an expert in our this important session of internet and cyber violence against adolescent. And I'm sure she'll be giving very important inputs about this topic. So over to chairpersons to start this session. Is Dr. Sandeep there? So Dr. V. Ganeshan, a very famous doctor with 30+ year experience as a pediatrician, worked in UK NHS hospital for 24 years. His area of expertise and interest, neonatology, pediatric nephrology, medical education, and quality improvement. He is a joint lead for quality assurance for 7 years, deputy regional advisor for RCPH in West Midlands, UK, academic director and clinical safety officer, Vijaya Group of Hospitals at Chennai, and president Tamil Nadu chapter of ANBAI for 23-25. So over to you, sir, for your talk. The floor and stage is yours.
Good evening. Can you hear me? I'll share my slides.
Yes, sir.
Yes, we can hear you.
Can you see my slides?
Yeah, we can see
Yes,
you.
sir. Very well. Okay.
Hi. Good evening, everyone. It's a great opportunity to be amidst such a esteemed group of colleagues. And I thank my good friend, Dr. Jairani, for giving me this opportunity to talk to eminent obstetricians. I'm giving this talk not because I'm a pediatrician, but more because I'm a lifetime student of human behavior and trying to understand many of the events in society and trying to sort of grapple with why something may be happening. So I've kind of shared my musings about the internet and cyber violence against adolescents and women, more from a perspective of a curious observer of society. The way I have just structured this session, as we all agree, this is a new age phenomenon. I'm sure I will come back to the elaborating on it a bit more. I think we need to understand a glossary of terms relating to them. And do you know, are we familiar with it? Do we know exactly what it means? Would be my question to the colleagues, just to understand how new this phenomenon is. And then I want to focus on the manifestations and impact of cyber violence against adolescent and women, and try and sort of reflect a bit on the origins of cyber violence against adolescents and women, why that is a special group, and challenges and potential solutions, if any, or what has been attempted. Um, Many of you may know that internet has been around only for a short time. I'm sure people of my age would have come through from the audio cassettes to VHS tapes to CDs to streaming device now. So for those of you, I want you to go back on the time machine and then think about what you're doing in these years. 1983 is supposed to be officially the birthday of internet. I was in med school at that time, just started second year med school, and World Wide Web is only just 35 years old, 1989. I could relate to the time when I had just finished my internship by then. And despite the now ubiquitous mobile phones, the SMS or the text messaging started just about 32 years ago. And the first SMS message in history, reading Merry Christmas, was sent on December 3rd of 1992 from a personal computer in London. So that's when I had just finished my MD Pediatrics. So as we all could relate to the timelines with our own life, the internet, World Wide Web, and the text messaging has been there only just about 30 odd years ago. We are still learning and exploring. Unfortunately, the baddies seem to be doing it quicker than the good people. So that is where understanding the origins of the crime and how to tackle it and what the manifestations have become quite important. Again, I would ask colleagues who are around in this webinar as to, do you know who we refer to when we talk of Gen Z? Of course, the answer is revealed there with the highlights. This is the group who were born between 1997 and 2012. So this is the group who would be most familiar with the cyber crimes. And they are the ones who are likely to be the victims and unfortunately the perpetrators as well. The reason why this is important is we need to understand what the Gen Z mindset is, Gen Z's favorite behavior is, and then we can get to the bottom of these problems to find solutions. In terms of why adolescents are special in terms of victims of violence, there is a United Nations publication on child and youth safety online, which talks about, compared to an overall 65% connectivity across the globe, across all ages, the 15 to 24-year-olds seem to be much more connected. About 80% of them are connected. And this connectivity gives them the opportunities, but also exposes them to the threats related to this connectivity. So looking at the manifestations or impact of how cyber violence affects adolescents, Again, there is a UN publication which talks about very specific risks of internet to young people. It starts off talking about cyberbullying and other forms of peer-to-peer violence, which is a big social evil, which is unknown about 25 years ago. But in a recent survey across 30 countries, about a third of young people felt that they are being cyberbullied, and about 20% of the children skipped school. Of these children who are cyberbullied, skipped school because of that, which is an unfortunate situation. The second major worrying threat because of the internet is the online sexual exploitation and abuse of adolescents. And this internet as a medium has made it much easier for the perpetrators to commit these offenses. And again, in a United Nations survey across 25 countries, 80% of children felt that they are in danger of sexual abuse or exploitation online at some point in time, which is a very worrying big number. In addition to these two major phenomenon, internet also exposes children and young people to hate speech and violent content, which may incite self-harm and suicide. And digital platforms can also be used as medium for disinformation and conspiracy theories, again planting unfortunately bad ideas in the minds of youngsters, starting from a simple sort of a bullying your neighbor or someone who's a potential victim to making bombs or become suicide bombers. Whereas children are also at risk by the greedy, rich tech companies who don't hesitate to breach their privacy in terms of collecting data which they monetize. So, unfortunately, this way, children could be targeted for marketing purposes as well. So, moving on to the manifestations or impact of cyber violence against women, we need to first of all understand what cyber violence against women constitute. In the United Nations Istanbul Convention, the cyber violence is defined as a very broad term, which includes acts of gender-based violence, including threats of such acts, coercion, or arbitrary deprivation of liberty, whether occurring in public or in private life. Why is it important? Because unfortunately, it is an increasing problem worldwide and it undermines gender equality and it violates women's rights. These are the reasons why cyber violence against women need to be recognized, tackled, and prevented if possible. And this cyber violence against women can take many forms, including cyber harassment, revenge porn, threats of rape, and even go on to become physical sexual assault or even murder. Unfortunately, the perpetrators of such crimes are often their partners or ex partners, colleagues, or schoolmates, depending on the circumstances. Having had some understanding of the manifestations or impact of cyber violence on adolescents and women, we need to reflect upon the origins of them. As the medical theories would go, when you understand a disease, you always think about why is it happening before you can find a solution. Whereas in this case, it is more understanding the society's behavior. And I've just put some thoughts together, which is not from any source, but it is my own thought process. So I would be curious to hear from our expert Inspector General of Police, Radhika ma'am, as to what her thoughts on this kind of analysis of the origins of crimes. Basically, there are two essential ingredients for any crime to happen. One is individual and the other one is opportunities. Individuals, there are population variations across the whole country or any sort of microcosm of a country you take. A minority of individuals are psychopaths who unfortunately are, I don't know, for whatever want of a better term, I would say they are born that way and are going to commit that crime anyway. And it is going to be incredibly difficult to influence them. It is only a question of recognizing the patterns and putting them away. Whereas a large majority of people who commit this crime will commit it if the opportunity is favorable. What do we mean by that? I'll just focus on in the next slide. But in terms of opportunity, so what determines who commits crime when? And I would define that there are different thresholds for every individual to commit crime, and these thresholds differ based on the society or the individual. For example, if you look at the crime rates in countries like Japan or Scandinavian countries, they are relatively low. Why is that the case? Because there are certain factors inherent in those societies which do not give opportunities or which do not create favorable opportunities for the criminals to commit something. The same way, individuals, again, we see a huge variation, even from within the same family. There are some individuals who commit crime compared to others, but again, there are certain profiling of people with certain common characteristics who may commit crime as well. So, this helps in crime fighting, this understanding of individuals who have a higher threshold to commit crime. Focusing on the opportunities, these opportunities may arise from a place. Again, interestingly, if you think about it, again, moving away from the cybercrime for a minute, the place would be, what I mean by that is, it may be, for example, in a crowded place, there are certain crimes which happen, like pickpocketing in the time of festivities, or in a crowded bus, or in a crowded street. Whereas when there is isolated spots, there are certain crimes of violence which happen because they know that they can get away with it. So that way, places offer opportunities. Same way, time offers opportunities. Certain times of the day, times of the year, or timing in terms of the set of circumstances which come together. Or thirdly, vulnerability is another key factor which which decides on the opportunities for those with a criminal bent of mind. That is where adolescents and women are vulnerable groups, as are elderly people and other vulnerable groups, actually. The fourth important sort of opportunity is what I have labeled as accessible tools. There are certain tools which offer opportunities in the hands of those who have the right threshold to commit crime. And internet is one such tool, as are guns in United States of America. Why is gun crime high in America? One of the simple answers is gun is available easily. The same way, internet now is available to everybody in the world. As the UN paper said, 65% of the entire world's population has got access to internet, and adolescents, about 79 to 80% of them. So unfortunately, they become the users, beneficiaries, and victims as well. So looking at it that way, what kind of attraction does internet offer? Impulsivity is one of those factors which plays in internet being a tool, because the Gen Z typically have impulsivity as one of those generation characteristics which define that generation. They react immediately to something which is said, and unfortunately, hate speech or something which is said, and people pounce on that individual, and that becomes a kind of cyber violence, eventually can smolder into something big. And this can happen even at different levels of society. Even so, one of the tweets, which is not a tweet anymore, an X coming from even Elon Musk, can start this kind of a viral trend. So impulsivity is a major attraction in internet being a tool for committing violence against individuals. The second attractive feature for the criminals about the internet is its anonymity, because somebody can be there in a remote place, maybe in the other part of the globe, but still commit the crime. Especially use of dark web, which I'm sure many of you would have come across, offers even greater level of anonymity, and the baddies are extremely proficient in accessing those kind of features of internet. And the third important element for use of internet as a crime tool is a message can be shared or spread very quickly. So if you want to destroy somebody's reputation or damage it, you can do it very effectively in the internet without any damage to yourself, because you are operating from some remote place. I mean, this is being engaged by not just individuals, but even sometimes countries do this. Again, I don't want to name the countries, but I'm sure you would be familiar with which are the countries which may operate these kind of strategies. So with this understanding of origins of the most crimes, we can look at what are the kind of solutions which are being broached or being sort of thought through at global level and in Indian context, and also as at an individual level, what can we, you and I, do about it? At a global level, United Nations is doing a lot of work in terms of protecting young people online. In terms of cybersecurity, it has got a Child Online Protection Initiative, which is a multi-stakeholder network. It has got an international, United Nations has got an international telecommunication unit, and that has published a guideline on child online protection with a comprehensive set of recommendation for all the stakeholders to develop and contribute how cybersecurity can be improved. I don't know how many of you know, every first Thursday in November is marked as an International Day against violence in bullying in school, including cyberbullying. So UNICEF has come up with UNICEF's Kindly initiative, which aims to end cyberbullying. And this day, annual day, is used as a kind of a marker to spread that message in trying to end cyberbullying. And in addressing sexual exploitation and abuse, um, We Protect Global Alliance model has been put forward by UNICEF, which strengthens the capacity of on the ground responders to provide services to victims. And there is also global coordination to address child sexual abuse, including grooming and sexual image abuse and cyber aggression and harassment. And in 2022, World Health Organization has published a report to prevent the online violence against children. Having looked at the global effort, I just was curious to glance through the newspaper in the last week, a couple of weeks, and then came across three news items which I thought are relevant to this context. The first one is about cracking of a major child porn network. And would you believe that the originator of that was a 22-year-old BCom graduate from Telangana, from whom they have recovered thousands of short videos and obscene images, which he has been selling for a fee. Sheer greed for money has driven this youngster who could have put his mind to some better use, but unfortunately, he chose to put it in perpetrating violence against children and sharing that image across the globe. The solution came from sophisticated detective work and policing from the New Zealand police, who spotted this individual's cloud storage of this offensive material. They not only deleted it, they highlighted the Indian authorities, who tracked him with his IP address and have arrested this young man. But this, unfortunately, is only one weed in a massive field of a lot of poisonous weeds in this place. The second news item which I wanted to highlight to you was a suggestion by a Madras High Court in a recent public interest litigation to raise awareness about responsibilities and actions to take. This solution tries to explore ways of raising awareness amongst the multiple stakeholders. And I think when we talk about violence against children, starting with schools seems a very good idea. So this suggestion of this Madras High Court judgment is that to include information in school textbooks, number one, about child helpline number, to give them the sort of opportunity to talk to someone if they are the victims, and also to remind everyone of the duties and rights as citizens relating to FOGSI provisions. This is for parents and children to raise their awareness and their active engagement in trying to recognize when these things happen and also prevent any such violence. And the third news item, which I found interesting, is a new initiative by one of the NGOs called Padai in Tamil Nadu, which gives second chance for first-time juvenile offenders. We know, unfortunately, once someone commits a crime, there is a very high probability that that person becomes a repeat offender. Instead, if you break the cycle of crime by trying to rehabilitate a juvenile offender, who are often frustrated, angry young men, using this particular NGO has worked using one-on-one counseling and group therapy to create interest for these juvenile offenders in arts and crafts and to get some livelihood out of these. Definitely, these kind of interventions in India either a court's intervention or an NGO's initiative or good policing across and coordination with global kind of a network of police forces are solutions which are here and now in India, and they would continue to happen, but unfortunately they cannot tackle the problem fully. Coming back to as individuals, what can we do? To understand that, I thought very quickly I would recap what I mentioned about the origins of the crime. If you follow that, then probably there'll be some ideas that will emerge as to how we as individuals can meaningfully make some impact on preventing and also recognizing the cybercrime and against adolescents and women in our either personal life or professional walk of life. So very quickly, the individuals and opportunities. The individuals, there are a large majority who will commit a crime if the opportunity is favorable and the thresholds differ. So we can do something about these thresholds. And in terms of opportunities, place, time, and vulnerability, and the accessible tools, unfortunately, we can't ban the ubiquitous tool internet, but we can do something about modulating it in a way to reducing its chances of becoming a tool of violence. So, as an individual responsibility, I thought we can prevent any crime or cybercrime by working on individuals around us and raising their threshold to commit crime. Any crime, more so cybercrime. This is about talking to the boys in our own home about how they should treat girls better, which has been widely talked about, preventing crime against women. The same way, school age children, again, talking to them as to how it is completely wrong to bully another child using the internet. I mean, those are things we can do in our own household. And also, as professionals, when we come across youngsters who are victims, probably we need to be able to recognize it and also advise them as to what kind of support network is there. The second important thing is we can reduce the opportunities of these kind of crimes being committed by diligent risk assessment. This is about internet use. Again, there are child filters, and it's a question of using that kind of a parental control and making parents aware that those kind of things would be good tools to prevent them. If the crime has already happened, then it is a question of recognizing the victims. This is again something which would be very much part of our professional a day-to-day handling of individuals, both as obstetricians and pediatricians, I would say. That we operate based on the trust our patients place on us, and the trust is the critical element to encourage victims to come out. One of the classic examples of such a lack of trust in the system, unfortunately, how makes the victims cocoon and not even want to talk about it, is a news item which is in the public domain from Kerala. The HEMA committee report, which has identified and 31 FIRs have been filed. But unfortunately, none of the victims want to pursue because they do not think that the system would fix the problem. So there need to be trust in the system, and victims need to be identified, and the resolution, rehabilitation need to happen in a timely manner. And finally, supporting the victims also in terms of mitigating their vulnerabilities and also them not falling prey again, or actions which as individuals we can take. I hope with this there is some kind of not just news item, but there is some thought process about how these are the origins of these crimes and what we can do as individuals, both in a personal capacity and also as professionals. That's my parting message. And with that, once again, I thank the organizers for giving me the opportunity. My pranams to everyone. Namaste, vanakkam.
Thank you so much, sir. Now, may I request our expert, IGP Madam, Mrs. Radhika, to please give her inputs for such an important topic, how it can be prevented or how we can solve this problem to some extent, or what's your suggestion?
Before Madam starts, I would like to introduce her. Mrs. Radhika IPS is such a dynamic person who is the right person today for this content. Why I invited her is she is presently the Deputy Assistant Commissioner of Additional Commissioner working in Chennai, and she is the one who is handling presently the crime branch which deals with the cyber crimes, and she handles a high volume of white collar offenses and cyber crime. Yeah, can I have the Madam is the very nice person who is a very dynamic person. She is the first Madam Niba Mohan, ma'am, if you want to say something, you can tell. I will just introduce a few things about her. She is the one who is working presently on the cyber. Very much active work presently she's doing as an additional commissioner in the Greater Chennai, working with a lot of white collar offenses and cyber crime. And she's the first women superintendent of police in Kadalur district in November 12, which is a very sensitive district due to a lot of caste clashes, labor issues, student issues, and also a lot of honor killings. And she was dynamically working all against these violences. And in that way, I really have a great honor and great pride to be a woman who works for the women. So with this word, I really thank the Mrs. Radhika IPS for joining us to share your expertise in this content. Niba Mohan ma'am, if you want, you can just add on the CV of madam also. That would be really great for all the viewers to know about her.
So I think you know much about madam. I just came to know about her, and she is such a senior IPS officer, and she has spared her valuable time to come and join this session. So we'll really like to hear from her for the important inputs from her. Those will be really very special for us. So over to you, madam, Radhika madam.
Thank you, ma'am. Thank you so much for this wonderful opportunity. Personally, I would like to thank Dr. Jairani for giving me an opportunity to be part of this August gathering, and also for giving such kind introduction about me. Thank you, ma'am. I hope I stand up to your expectations. Just give me a few seconds to share my PPT. Entire screen. That's it.
Yes, madam, we could see it.
Yes, ma'am. Thank you so much, ma'am. I would like to thank Dr. Ganesan for making my job very easy, as he has almost covered most of the points which needs to be introduced about the subject which we are speaking about today. And ma'am, hope I'm visible and audible.
Yeah, yes, very much, very much, ma'am.
Very clear.
Thank you, ma'am. So I would like to just give a small introduction about what is cyber stalking. So all of us know that whatever, when we were young, we were facing stalking on the roads, colleges, buses, everywhere. But now it has become more common due to the usage of cyber space over every walk of our life. And cyber stalking is the use of internet or other electronic means to stalk or harass any person by misusing the uploaded information on the social network sites. So it can be in any form. As all of us know, it can be a harassment, it can be an embarrassment or humiliation of the victim. And it has gone to the extent that emptying somebody's bank account by using various uh, reasons. Like of late, we are talking about this digital arrest and everything, which I would just touch upon at the end. And taking over your entire economic control and spoiling your credit score, everything. Then sometimes it goes to the extent of harassing the family, friends, and the employers
to isolate the victim. We should not underestimate this point, because we have been having complaints in which the ex-husband of an employer or a victim had used their intimate photos and shared it with the employer. And the employer was very clear that unless and otherwise you clear this and come, we are not going to give you employment. Already the lady, the victim with the child, and deserted by the husband. So her economic independence was her strength. But when they are spoiling that, this puts them in real trouble. So let's not think that the cyber staking or the cyberbullying stops just with an individual, but it spreads across your family, friends, and employees also. So the scare tactics, the main intention is to scare tactics to instill fear and other things also. So I would like to just share a small generally, who are the victims? Anyone who can be victim of cyber staking, but mostly it is females. And when we compare with the male population, it is mostly it is a female, which has become a vulnerable thing. And another reason is, as Sir was mentioning in his presentation, educational institutions are also a very likely target of cyber staking. We come across such complaints from reputed institutions, IIT and Anna University, as these guys are technically very sound and they are using their knowledge in a perverted manner to exploit their own colleagues, their own classmates, like that. So this is a small case which I'm just making a pictorial depiction how we digitize our life. Every morning we get up, we just say good morning, good evening, good night. Everything ends with our social, only in our social media. So I don't know whether how many of us share the good morning, good night with our own family members, but we don't fail to share that in the social media. So just an example, a girl would have been an NRI and she has come India to study and she just wants to live her life to the fullest. So she is in the habit of posting everything, whatever, in the uploading in the social media, and due to which she has got more than 10,000 plus followers. And a day she decided to go to Goa on a solo trip, and she updated her entire plans on the her wall with the itinerary. Then, as we just presenting that one Kiran who has been staking her in her social media pages. So he had been an habitual offender and just come out on bail. So he has followed her to Goa and texted her that he is in a hotel room and expressed his desire to meet. What way you're connected? So this is one example, but we have seen like house burglaries taking place just with a simple thing of saying that you just post a photo of your family standing in Kashmir or Goa somewhere, and one of your friend asks a nice location, where are you? Then you just reply, I'm in Goa. How long? Next 1 week. So there are continuously, then you give your entire plan. There are a lot of, it's not that our social media posts are visible only to us. Most of the time we don't even audit who are all can see our posts. How many of us have audited our Facebook pages and which can be seen only by our friends, or even check whom to whom these posts are visible? So when we are making such things, you're opening your door to the whole world. You're only inviting the thief to come. So this is one such incidents where we have come across. So my only request is that please do not digitize your life. From morning to evening, please do not digitize your life. It is we who are making our own life open to the world. Then later on, there is no point in repenting or complaining about somebody or some pervert coming and entering into our private life. So this is one such incident So there are few preventions I would like to mention. So all of us must have heard about the word keylogger. It's a small software which can be sent to you through a link, and once you touch it, it gets installed in your phone or your laptop, anything. So whatever you type, they can easily observe and can use for modifying your photos, for modifying your password, everything. So the key point is that please do not touch any link and open it unless and otherwise you are very sure about the sender, or it's from us, from your own circle, and you have been expecting a link to attend to something or otherwise. And do not share passwords with anyone, including, to be underlined, including your spouses, fiance, everybody. Kindly give this advice to your children who are in the adolescence, as they are in the habit of opening common mails, sharing every password, and they exchange their emails for getting. And sometimes you store your photos, everything in the cloud. And when the relationship gets strained, there is every possibility of your photos or your personal details getting misused. And don't store your passwords on browser without proper security. Not necessary that everything needs to be stored every time we should type our password and not to be stored anywhere. And kindly avoid sharing your phone with unknown persons. Not only unknown persons, as far as possible with known persons also, unless and otherwise it is very important, or it is required at the time point of time. Then I would like to touch upon the cyberbullying, which is in an electronic bullying. Instead, people bullying others in person, they are doing it online these days. So where cyberbullying can take place? The common sites are Facebook, Instagram, Twitter, MySpace, websites, or any kind of online games. These days, the adults are very much interested in playing online games. They get into a lot of private chatting apps in which they share everything. Just for the sake of playing games, they share everything. So these are the most commonly used places of cyberbullying. What are the effects of such kinds of things? It develops an anxiety. Once you know that some of your private things are being shared or it has been exposed to the society, you get into a lot of anxiety. What next is going to happen? So that spoils, it's a vicious cycle. So it affects your sleep. Sometimes longer poor sleep leads to depression and sort of unhappiness, and it leads to loneliness, because there are a group of people getting bullied. We see in the social media day in and day out. If somebody decides to victimize a person, so a lot of people with unknown IDs or anonymous IDs, they keep victimizing the person who's ending up in loneliness. So just few points for everyone to ponder, do's and don'ts. So the very important thing is password best practices. These days, very often we are seeing the Telegram app being hacked, and a lot of us getting a message saying that your friend so and so has shared the photos with you, and when you open that message, you will see a link, and it will be automatically suspicious. To avoid such things, I will suggest that please keep a strong password, and it is a must that you should have two-factor authentication or multi-factor authentication, if not at least two-factor authentication. And as every site or every expert says, kindly use a longer and complex password, and do not have the same password for your banking, for your email, for your social media, everything. Don't have the same password. And don't keep your date of birth, your child's name, your spouse name, your place of stay, everything as your password. And kindly mix lowercase, uppercase, numbers, special characters, everything, so that it makes it little complicated. And as I said, now not to share your phone, don't share your password also. We have come across in which very highly placed family, when in trouble, they started misusing their uh, photos and the mails, correspondence which had in their emails, because as spouse they had known each other's mail IDs and passwords. So kindly avoid sharing, and do not store your password in any browser, and aware of keyloggers, already I've mentioned. Use different passwords for different accounts. Then kindly never use your any public system for accessing banking and sensitive sites. Kindly use your personal gadgets for using them. And any questionnaire which you had to fill, never give your password, or any security forms also kindly avoid giving your passwords. And do not store or select remember password option for banking and sensitive sites. Kindly ensure that you enter your password every time. And social media profiles, if you get, even tomorrow you may get a profile with my photograph asking, saying that I am in trouble, kindly send me 10,000 rupees. And such things are happening. It has gone to the next level, in which the children are told that your parents are in trouble, your family is in trouble, come kindly come with the person who is standing near your school or something like that. Or other places, the doctors, we get a complaint that and the hospital staff get an information that I immediately need so much of money, so transfer to this a particular account. The staff, without verifying, they just see a message in the mobile with a photo of their boss, and they transfer the amount. Later on, they keep asking for more and more amount, and that is the time when they become aware, because sometimes it crosses their ceiling level. So when they start verifying, why is the doctor going to ask, or why is the boss going to ask money from their staff, and that too to send from an official account for their personal expenditure. So kindly be aware, even when you see a photograph, just make a call whoever is sending you that message, to confirm that it is from your friend or your colleague. And please do not yield to these advertisements saying that you can make so much profit in your online trading, everything. And now, in the recent months, many of our victims are doctors who are into online trading. And because they are introduced through some WhatsApp messages or Telegram messages, where they are asked to join some groups. In the group, they post a lot of messages saying that so much profit I have made today, I have made this much profit, and I have withdrawn this much, and I'm reinvesting this much. So all these things are only a temptation to be created in you, and you end up investing. And there will be an app in which you will be investing, and that wallet of yours will be showing that double profit, triple profit, everything. And day when you decide to withdraw, you will not be allowed to withdraw your money, and they'll say, now if it is 3 crores, please send us 10%, 20% more for you to withdraw. Then you end up giving that, thinking that you're going to get entire money. At the end of the day, they don't get anything. It's not only they are spending from their own pocket or from their savings, they are borrowing from the friends, colleagues, family, and doing. Ultimately, they end up answering everybody, and it is a very difficult process to retrieve this money. And as I said, kindly check your privacy settings regularly in all your social media apps and your email, everything. And keep checking your phone whether you need every app regularly, or if you don't need them, kindly delete them. And in your phones and other things, please use this DND service to avoid unnecessary calls, all these inviting calls, please avoid them. And please beware of the loan app, because we see more this in the age group of 18 to 24, where many of them are in need of money to start a small investment, to start a small business. So end up approaching these loan apps, because they think that the procedure is very easy and they get the money immediately. They may get a small amount of 10,000, 20,000, and they end up paying more money. And when they stop paying, thinking that I have paid double the time of what you lent me, these people start morphing their pictures, because when they took the loan, they never checked what are the access they have given. You end up giving access for your photo, your mail ID, your contacts, everything, which is not required for a loan app. Better please go to a bank and whenever you want to use something confidentially, please use SD card, or you can have a hard disk instead of keeping it in your phone or in your laptop or in a system which is not all the time connected to an internet. And kindly check your bank statements frequently, and because these days we are checking more our WhatsApp messages than checking our SMS. And most whichever my other suggestion is, whichever phone number you have given for your banks, kindly do not connect with any social media. And the other thing which is becoming very common these days is searching for customer care number in Google. We are not sure whether it is the particular customer organization which is putting that. Rather, if you want your bank, please take your passbook or go to your bank site and take the customer care number, and do not take Google. Go for Google and search for the number. Most of the time they are all what shall I say, it's all trap. Whatever you have numbers, they are all the trapping mechanism. And similarly, always update your any app only from your app store and not from the browser, because the browsers may mislead you. And similarly, avoid updating notifications, and avoid scanning important confidential documents over phones. Use a proper scanner. And I know we are all very tech savvy and want to make our children also tech savvy, and we start teaching them a lot of things, and many of them want to experiment. Whatever POXO cases we are getting, we see that many I can't say them accused, they are the juvenile who just see what is in the internet and they just want to practice it in real life. And what happens? The victim is a juvenile, young, 13-year, 14-year, and the boy is also 15-year, 16-year. Imagine their future. Imagine the future of both of them. So whenever we give phone to the younger ones, kindly be aware of with the child lock and with all precautionary measures. And if you have given a separate phone or a gadget to your child, please audit it regularly. Yes, we should have confidence in our children, but the society gives them so much opportunity to get exploited. So kindly have a check on the phone and their whatever gadgets you have given them. And whenever you come across such complaints, my request is that kindly do not hesitate. Immediately give a call to 1930. I know sometimes it is difficult to get 1930, but it's a call center. The number is become quite famous now. And other option I can give you is the National Cybercrime Reporting Portal. These two are exclusively for reporting any cybercrime, and especially 1930 is a financial fraud number which is an instant helpline for you. So the advantage of giving complaint to these 1930 and the cybercrime reporting portal is, if you have lost some money, automatically there are systems through which they can block the further flow of money. Like from your account, it has gone to X account. If you have lodged a complaint immediately, let's say 4 hours, 5 hours, 6 hours, so it can stop the further flow of money to Y's account or A's account. So that way your money can be retrieved. Or if you're using your account, if somebody has made a purchase in Amazon or something, before the good is being dispatched, or the money can be reverted back to you. And before making any such complaint, kindly keep all these things available. They basically need your name, mobile number, email address is optional, and address of you, so that you can locate and your complaint can be sent to the concerned cybercrime police station. And whichever number, the suspect number you have got in your phone, or your other links which you got, sometimes through a link your phone is also being hacked. So, and your bank ID, UPI ID, your debit card in case of card transactions, and kindly keep the bank transactions if you have transferred money or you have involved in online trading or the very famous FedEx scam or digital arrest. I would like to take few minutes on that because more and more victims are getting reported often. And as our Prime Minister said, this year 1,400 crores is the volume lost in online financial frauds. So just imagine, and I request that do not fall prey to any of this digital arrest. Somebody calling you, there are 2 3 MOs, just I will mention 3. One is try, this Telecom Regulatory Authority of India, giving you a call or a phone message. It will be a typical phone message which we will get, that your phone bill is not paid. If it is not paid, kindly press this number 1, number 2, number 3. And similarly, never ever we get a call from or message from try. Second is FedEx. Your name, there is a parcel which contains narcotics or banned items, or using your Aadhaar card, a money laundering has been done. So much cash is in your account which needs to be sent. So this is another one. And the third one is that if you have a child who's studying, they call the parents saying that your child has been just arrested, and for the offenses for possession of narcotics. We know our child has gone to college. Why should we get panicked? Why not make a call or just check up with the college whether the child is there or not? Without confirming that, the victim start transferring the money. So no police department, CBI, enforcement, or anybody else approaches anyone over video call or a Skype call, or there is no concept of digital arrest. Kindly make awareness to all your known people. So when you're making complaint, kindly keep the suspect bank account details, whichever ID you have transferred the money, transaction date, time, everything, for immediate freezing of your amount. And if it is other than financial complaints, loss, if there is morphing of your photo or misusing of your photos using some other ID, or your email has been hacked, website address you are suspecting, all these things also you can make complaint in the cybercrime reporting portal. And keep your bank statements, screenshots of your transactions, and any other evidences available. And I hope with the time available, I have touched upon the important aspects. Ma'am, thank you so much for this opportunity. If anything further clarification needed, I'm open for it. Thank you.
Thank you, madam, for this wonderful, very, very important and very much needed information you have given. Over to the chairperson. Thank you so much for joining in midst of your busy schedule. Thank you for sharing all your expertise and all the very important information that we should look into us, because we doctors, we being very busy, sometimes we don't know what to do, how to do, and all this technology makes it into still more a problematic one. Sometimes without knowing what is what, we land into troubles. Really, your presentation showed us a lot of way how to look into it. What are the things that we should look? Thank you so much, madam. Thank you.
Thank you, ma'am.
Thank you so much, madam. Dr. Jairani, I think we should have a webinar on this topic only. Such a huge, in-depth knowledge madam had shared that we could have asked so many questions. I think delegates could have asked so many questions.
We can cancel the panel and ask madam to talk another half an hour.
I think so. Panel can be taken anyhow, anytime.
Really, madam, most useful information. Thank you so much. And we are getting nowadays more and more calls, means the criminals have become so daring that they know that information is being circulated. Still, they are doing the same thing. Every day, phone call from TRAI. Every day, FedEx parcels are arriving. Every day, our children are
And
selling
surprisingly, call from army person that I have to get examined 15 female at a time. Please, please give number and please come on video calling. Please show your face and we want to talk on video calling. So I mean, And recently, my daughter call has been hijacked number and WhatsApp, and her friends, they were so generous that they transferred 10,000, 20,000 to her, account. And she could get out of it within 3 to 4 hours, but by that time, 2, 3 friends of her, juniors of her, they
No,
transferred
kids went
money.
into a lot of
This is
trauma,
50,000.
unwanted trauma they undergo.
I know. And the whole friend circle and the family and the extended family, they all were so tensed up for those 4, 5 hours that what's going to happen. But somehow they could
Madam, that
manage,
Goa,
and
can you please
finally.
just tell me the follow-up, because that time my network went, so I couldn't get the what happened to that person who stalked her and went to followed her to Goa, for girl who was putting on social media. The network went, so I'm now interested in
It's a very interesting detective story, Shiva.
Man, then I should talk for 1 hour. No, but actually he was secured and he was put into jail again.
Oh my. Okay. Thank you, ma'am. Really pleasure hearing from
Thank you, really.
Yeah.
Yeah.
Thank
I
you
didn't
so
know
much.
that.
Thank you so
We will get such a good presentation from Madam as well.
Yes.
So we could have planned in that way.
Thank you,
Thank
ma'am.
you, madam.
Thank you
Thank
so
you.
much.
Thank you.
Thank
Thank
you,
you.
ma'am.
Thank you so
Thank you,
much.
ma'am.
Good
Thank
night.
you with regards.
May I leave the session now?
Yeah,
Yes,
ma'am.
thank you so
Pleasure.
much.
Okay.
Thank you. Thank you, ma'am. Good
Yes,
night.
thank you.
Continue
Good
enjoying.
night.
Yes.
Okay. Thank you. And with that, that's the end of the second session. So moving to the third session, most probably Dr. Aruna.
So
Okay.
all were going very well, Dr. Aruna.
This is an excellent presentation.
Priya, in between, I'm
Thank you.
just
Thank you,
talking.
Dr. Jairani, for bringing her. We got so much of knowledge. Really, it's very scary, and we should know the facts, whatever is happening, right?
Yes.
Thank you so much. And let me have the pleasure of introducing
Madam,
the
I'll just
next
tell
moderator.
one incident.
Doctor, yeah,
One
tell me,
of my family members, this one got hacked, the account, and another means my cousin put in the group, okay, this auntie's mobile number is hacked. So that hacker deleted that message from the group. So smart they have become, just see.
Yes.
Yeah.
Even
we won't
we
be
got
alone.
a message from my daughter's phone. Hi, mummy. Hi, papa. Everyone, like,
And
we have to
now with
respond.
AI,
But
though, they are
they
hating the voice
respond.
also, na? With AI, the voices also they are phishing. So it will really sound like your children. It is very difficult.
How the hacker is in the group, that is a mystery.
Yeah. Means one of the phone number was hacked by the hacker, and through that hacker had access to the WhatsApp group, na? So one other cousin put ki the auntie's phone is hacked. Don't give any money. So the hacker saw that message and deleted it from the group.
I know.
Just see how
Such
smart.
a,
Yeah.
That's too much, Supriya.
Yeah, it happened first time.
it's happening.
Then,
It's happening.
then I told the admin was that auntie whose phone was hacked. But
Oh.
luckily there was one more admin. I told her first thing, remove her as admin and remove her from the group. And when
Okay.
phone is not hacked, then you can add her back. First thing, remove from all groups.
Yes.
Okay.
I
Let
think
me
that's the
introduce
best
you.
panel discussion.
Yes,
Yeah,
this is
Supriya,
important
let
panel
me
discussion.
introduce you. I welcome you, Dr. Supriya Arwari, consultant obstetrician and infertility specialist, MD at KEM Hospital, Vadia Maternity Nursing Home, Maternity Hospital, say G5 Medical College, Mumbai,
Madam, I think it's
practicing at
okay.
Supreme
Now we are
Hospital.
running behind time. We can straight away go for panel, I think.
Yeah,
Yes.
please, I welcome
Yes,
you,
we
Dr.
all know
Supriya.
each other. That's
And
fine.
you are always spreading happiness, the laughter. Thank you so much. So always everyone feels happy when they look at you. And I love
Right.
being your
Sweet of
friend,
you to say
Supriya.
that.
Very nice. See, look at that laugh. Everyone is so happy. Come on, you continue with your panel. And
Yes.
next moderator is Dr.
I'm
Niba
there
Mohan.
already.
Yes. Welcome
Yes.
you, Dr. Niba
So
Mohan.
thank you. So we'll be starting with the
Can we
panel, me
quickly
and
run through
Dr.
the CVs
Supriya.
so that, yeah.
Yes, Dr. Datta's CV was there.
No, I think I will just invite right away because some of the very few people I think have joined.
Okay.
So
Is
without
Dr.
further
Datta
ado,
there?
I will start my slide share, and I would like to invite my co-moderator, Dr. Niba Mohan, and our panelists, experts, Dr. Datta Panandikar, Dr. Lalita Bajaj, and Dr. Gauri Karandikar. We also have our panelists, Dr. Aarti Nimkar, Dr. Minashi Deshpande, Dr. Supriya Rudra Gopal, Dr. Bhagyashri Ranjwan, Dr. Ujwala Bardapurkar, Dr. Priya Kannapan, Dr. Chitra Thyagarajan, and Dr. Anjali Kulkarni. And we also have Dr. Sneha Buyar and Dr. Supriya Jaiswal on who are there in the session. So if there is anything at all, we can also take some inputs from them. So,
and as experts, we have Dr. Datta, Dr. Lalita, and Dr. Gauri. Dr.
yes.
Jairani is there.
Yes. So let me just give a quick introduction to the topic. If PCOS there is nothing new that we can talk about as far as the definition or the criteria are concerned. But important in adolescent age is that the criteria which are applicable to adults or the symptomatology which is applicable to adults may not necessarily be applicable, and hence we are also discussing PCOS. In addition, we all know that PCOS now is gaining epidemic, in fact endemic proportions. More and more girls are being diagnosed as PCOS, and that is why the importance of this case. So Dr. Niba, can you start with the first case?
Yes. Who are the panelists there? Are there any or no?
1 minute. I will just, can we have a quick head count? Dr.
Yeah.
Aarti Nimkar, are you here?
Dr. Priya and Dr. Chitra are there, madam.
Dr. Priya and Dr. Chitra.
Yes.
Okay,
Only
Dr.
Dr.
Aarti,
Priya and Dr.
Meenakshi.
Chitra. Dr. Aarti was
Valid,
there.
I mean, like, I will.
Dr. Bhagyashri. Dr. Bhagyashri.
Bhagyashri is there.
Dr.
Okay.
Bhagyashri is there.
Yes, and
Dr. Aarti,
Meenakshi, Supriya Rudragopal, Ujwala is not there, Anjali Kulkarni, Dr. Datta is not there, Dr. Lalita and Dr. Gauri.
Sahiti, can you rename, like, once you have like identified?
Dr. Aarti, Dr. Meenakshi, Dr. Supriya Rudragopal, Dr. Bhagyashri is there.
Yes, ma'am.
Yes. Dr. Monali is not there. Dr. Ujwala is not there. Dr. Priya and Dr. Chitra are there.
Dr.
Priya and
Anjali
Chitra,
Kulkarni.
Dr. Anjali.
So we have two of them amongst us, and we have Dr. Sneha Buyar and Dr. Supriya Jaiswal. So we can request them to be the experts since our experts have not joined.
Okay.
Yeah.
And as a panelist, we have Dr. Bhagyashri, Dr. Priya, and Dr. Chitra.
Yes. Yeah.
Okay. So starting with the first case, girl 13 years old, having infrequent periods since her menarche, that is 1.5 years ago. Her mother comes to us, and as her elder daughter has already been diagnosed as PCOS, and she was worried and she came to us. So significant history of this patient, that age of menarche is 11.5 years. She's having oligomenorrhea, like cycle interval 45 to 60 days, bleeds for 7 days, occasionally heavy but painless. Her elder sister had the PCOS. So how will proceed with this 11.5-year-old girl with this problem? So, Dr. Bhagyashri, will you like to do ultrasound?
Yes, ma'am. First, counseling of the patient and patient.
Okay.
And I will advise ultrasound.
Yes, ultrasound. How you like to do? By abdominal or transvaginal?
Abdominal ultrasound, because she is unmarried girl. So
because she is unmarried girl. If you are thinking that she might be having a polycystic ovary, what are the findings which we usually see? Like enlarged ovary with multiple follicles.
Multiple follicles, more than 12 numbers in each ovary, and ovarian volume is more than 10 ml.
More than 10
and there is increased stroma, thickened stroma is there, and follicles are arranged peripherally. Most of the pearl necklace appearance is there.
You're not supposed to do ultrasound for any adolescents.
Yeah, I was like, if you asked us, I would definitely not do an ultrasound for this girl.
Especially for 11.5-year girl who has not even completed 2 years of menarche.
Yes.
So ultrasound is not needed for this this girl.
Yeah, and even in otherwise, madam, like adolescent PCOS, we don't need an ultrasound to
that is
diagnose.
the thing. That
If
is
she has an
especially
oligomenorrhea and she has hirsutism, those are the two compulsory criteria to diagnose. And then again, in less than 3 years of menarche, we definitely never diagnose PCOS for that. But only one thing is that she has a family history of PCOS, and we know that it runs in the family. And if there is a lifestyle issues, like if the child is obese on the higher side, I will definitely put her on a healthy diet with some sports activity into the child's life. Like, many of the child
Moreover,
are like,
in these
not.
patients, the morphology is also very confusing. It's all the same like polycystic. So
Yes.
it's, yes.
You should be able to
also
differentiate
in adolescent girls, the only reason that you would want to do ultrasound is
So I would just like to make one point here that
other tumors. Yeah.
yeah. Hello,
Yeah,
Supriya.
yeah.
Madam, yes.
Yeah.
Yes, ma'am.
So,
Yes, ma'am.
for the adolescents, it's, you have to diagnose PCOS if at all, that is on clinical criteria as we say.
Yes.
And you have to see that whether it is a normal transition or whether she is at risk. If at all you have clinical hirsutism along with the menstrual irregularities, then only you go for further investigation, at least for 8 years of post-menarche, what we call
Perfect. Yes, ma'am.
timing age. You should not insist on diagnosis of adolescent PCOS only if you have clinical features of hirsutism which you feel they're other than PCOS. So in that case, to rule out,
Ultrasound is indicated.
you have to go for ultrasound.
Madam, the other reason why you want to do an ultrasound on this girl is to make sure you're not ruling out any pelvic other pathologies.
Other pathology.
Germ cell tumors.
Yes, exam only you will come to
Definitely role of ultrasound is there, but when we interpret, sonologists have habit of writing PCOS and sending.
Yes.
And then it is like a stigma to that poor girl and her family is helter-skelter. So we need to counsel that polycystic ovarian morphology is not equivalent to polycystic ovarian syndrome.
Right.
Yes, perfect, ma'am.
Dr.
That
Priya,
is a very bad
years
part of
post menarche.
those
And Madam has absolutely
ultrasonologists.
rightly said 8 years post ultrasound, post menarche, ultrasound can be used as a criteria. So that is exactly the reason why
The clear-cut message is only to rule out other pelvic.
other problems, other pathologies. Absolutely, madam. And of course, to exclude pregnancy, just because she is a young girl does not mean she is not having a pregnancy amenorrhea. So that is exactly the reason why this case is being discussed. Yes, Dr. Niba, can you please continue?
Yes. No, I was saying that it's not a very good part on the part of sonologists that they write PCOS and the patient enters in your room. What is your problem? I am having PCOS.
PCOD,
No problem, nothing.
I am a PCOD. Patient comes and says, I am a PCOD.
No,
I am a
in this
PCOD. Yes. So you have to spare some more time to convince that no, you please come out with your symptoms. So these are the common problems. Anyway, so will you label her this patient as a PCOS? No. So we have discussed still not, like she has not completed 2 years of menarche. So we won't label her as
immaturity of the HPO axis. We can just reassure her that we
That's
can
a
just
very
wait for
important
some more time.
ma'am. Only if at all there is a persistence of symptoms or the patient obesity adds on to her, then only we have to consider, yes, after 2 years or after 8 years, they are reaching the adulthood. Or else I don't think so, only counseling is more than enough.
Yes.
So that is exactly how the take-home message is, that you cannot label her PCOS unless she is minimum 2 years post-menarche, because in the first 2 years, the hypothalamic hypopituitary axis is trying to get mature, and that may also cause very, very similar symptoms to PCOS.
True.
Ultrasound to be done only for diagnosis 8 years after menarche. Ovarian volume is important, and multifollicular pattern has no relation with the hyperandrogenemia. In a healthy girl with regular cycles without hyperandrogenemia, PCOM should not be given importance, because PCOM is something that very commonly gets reported in, especially when an sonologist.
Yeah, and the number of follicles also, like now the count is gone up to more than 20 and it's no more 12 follicles. So previously we used to say 12 and now the count has gone to 20 or 25.
So and size should be less than 10 mm.
10 ml, yes, ma'am. They stick on to 10 ml, and
important is the volume of the ovary.
Yes, and if you don't have a very good quality machine, where you cannot get the total count of the follicles. Then in a single plane, if you get more than 10, then again you should think of PCO morphology. Like, if you don't have a very good higher end quality machine where you can count all the follicles, then in a single plane, if you get more than 10 also, we can suspect.
Right.
So how will you manage this patient?
We should not use even the Rotterdam criteria for diagnosis of PCOS in adolescent.
In the adolescent, yes.
That is very important.
Yes, ma'am.
Yes. So just few words about management of this 11.5-year girl with irregular period.
So if
I think as Priya told, first is the lifestyle modification. As she told, just first important. I don't know the BMI. So whether it is in a patient BMI is checked, if you're finding is overweight, that might be the reason. So increase in testosterone level. So by doing exercises or lifestyle modification, even they have shown that 4 to 5% of weight reduction have shown to have a voluntary cycles, regular cycles, reverses the insulin sensitivity, those things. And if at all patient has having other cosmetic problems because of acne or hirsutism, then considering our severity of the symptoms, then OCPs can be given as a second line of management. But first line is always a lifestyle modification.
But sometimes we do see like cases where the adolescent comes to us and they're on the lean sides, madam. They're already very thin, malnourished. And even for them, I think a healthy eating habit should be re-emphasized. A high protein, high fiber diet. Like, they just eat like junk, only chips. The diet is like only chips and
That is
carb
our
diet.
advice, that don't take junk food, don't take snacks, more snacks item. You have to take homemade healthy food, and you have to be physically active, proper sleep, proper day-to-day physical activity. So that should be our suggestion to her and to her mother. So thank you so much, everyone. Moving to the next case.
Yes. I will just go to the next case now. So basically,
you can please carry over because I have an emergency. Let me see, and then I'll come back and join to you.
Okay, no problem. Yeah. Okay, so the second case is now, this is a 16-year-old girl, again unmarried girl. Her menarche was at 12 years of age, and she has come for a consultation for irregular menses. Since the age of 15, she used to miss her periods frequently, and attending doctor had given her diagnosis of PCOS on the basis of an ultrasound report. She was advised low dose OCs, which she took, and the periods were regularized. But once she stopped the OCs, that was around 6 months ago, again her oligomenorrhea has returned. Now her LMP is 4 months back. Now this is really a typical case, who is now going from pillar to post because she's can't regularize her periods moment she stops her medicine. Now, how will you go about this patient? Would Dr. Priya like to take it? Dr. Priya?
Yes, ma'am. So this patient now, she's again 16-year girl. So now I think we will definitely give her a withdrawal period. There are two types. I definitely prefer to give a withdrawal period. And if the withdrawal period doesn't work, then I go for a scan. I don't go for a scan directly. Sometimes the endometrium can be very thin, and just with Meprate, you may not get a period. You will need to add an estrogen also. But that need not be done as a first sitting. I assess the patient. Sometimes when the mother will be very worried, like they can be, like really anxious. And if there is a little suspicion of pregnancy, then definitely a scan will be better, because we cannot suggest UPT as of now in Indian scenario. The mother gets very agitated. So in that case, then we do a scan. Otherwise, I go with withdrawal bleed. If it doesn't happen in 10 days, then I go for a scan.
I agree with Priya. Along with the withdrawal bleeding, we can continue with other newer
lifestyle
generation
advices
also. So which has less anti-androgenic effects, all those things, because OCP is given to up to an age of what you call adulthood, like 3 years to maximum 4 years can be given in these patients. Only first immediately we should not give, because it will affect the bone growth. So I think so with lifestyle modification, OCPs, even there's a role of metformin if the patient is obese and having a high risk, because 8 to 10% of patients are known to have abnormal GDT. So in this patient, even metformin can also add, which might help in weight reduction.
I beg to differ, madam. I never had metformin in the adolescent. I don't like the way, because they get that I think of sugar tablet, diabetic in them. So even if it is an altered GTT, only with diet and exercise in the young child, it comes back to normal, madam, most of the time. So like, if it doesn't happen, if it fails, then that is the next step. So I don't think.
Now, do you think no myoinositol can be added, which is as effective as this
Yes,
thing?
now
Like
we have studies which says, Madam, myoinositol
So,
can be given in adolescent, but still we don't have any proven beneficial even for the adulthood. So now even like they say it's experimental, can be tried. We don't have any papers to say that myoinositol has a role. So for
and
adolescent,
we are doing one
we don't
RCT. We are doing
usually.
RCT. We'll come with the
so
results.
can I make a comment here?
Yes,
Yes,
actually,
madam,
Sneha
yes.
ma'am, I wanted to add the next question also to you.
Yeah. So
If we do
before
cycle
that, I'll
regularization.
just make a comment here. Considering this 16-year-old girl,
Yes.
the BMI is not mentioned, but I would still like to say that the OC pills should not have been started right at the beginning. And lifestyle modification, and lifestyle modification, because all of you know that even reduction in 5% of the weight and BMI leads to regularization of the cycle.
The only problem, no, madam, we all try to do that in the clinic. I even spend half an hour talking about lifestyle, and end of the day, the mother comes to me and says, okay, doctor, enough of talking. Will you give medicine or not? So I'm forced to give tablet. You have like no other option.
Yeah, Priya, agree to you, but I think we need to spend little more time, and we have to be evidence-based, You just ask her. What I do is, I ask that girl, you can search on Google. You like to search on Google? Please go for treatment of PCOS. It is on priority lifestyle modification. And I always tell them that if you go for OC pills right now, then her bone mass, as well as, bone mass is reduced, and even her epiphysis fused earlier, so her height becomes stunted. So that she won't like. That is one. And the OC pills, no, the mother will definitely not like that her daughter should take OC pills, because they also read it.
The
Now,
only point here, no, madam, when they come at 16, sorry, madam, to interrupt, that is that the 10th standard or 9th, 10th, 11th, 12th, that period, madam. And usually, like they spend all the time with books. So they never have any time for even eating or like, having a little bit of walk. So I definitely, like I've never seen people, giving importance to lifestyle at this 10th, 11th, 12th standard, madam. Maybe after the college, they'll come back and spend some time. Otherwise, they all give priorities to studies. I mean, that is how my patients react.
That is true, very true.
Yeah,
That is true.
but
This is a practical problem, agreed.
Yes, this is a practical problem, definitely, but you should take, the parents on your side. And some of the times, most of the times, I would relate even my kids to them, that our kids also have gone through this phase, and this is what they have followed. And it's good that, without medications, if at all you can go through, but it is working, no problem. But it's not a miracle that, but if at all, you have to have that persistence, consistency, and perseverance, then only she can go through. Definitely, you can have a withdrawal, periodic or cyclical progesterone withdrawal along with
I
lifestyle.
think cyclical progesterone is a good option, ma'am. When we have to ask them to take
That is
from
why I
day
put
14 to
this
day
question,
24, many have
whether
responded.
you prefer OCs or you prefer progesterone in case the patient demands that she would like to have few months of regular cycles.
I actually I tell them they can take withdrawal once in 2 months, because we just want 5 to 6 cycles a year, madam. So for the initial phase, so I feel that, you can take at least once in 2 months so that they have 6 cycles a year. Good enough, they will not have. And I tell them that lifestyle, it may even become more regular without a need for tablet. So just advise, and I tell them that.
Cycles not less than 8 per year. That should be the target. And you should not be, leave that girl to have unopposed estrogen action. So I think that is the basis, that better that you go, and by the time, her body itself gets reset. So that is also one option, I think.
Dr. Supriya Jaiswal, would you like to make a comment on the hormonal therapy? Dr. Supriya is there? She's logged in, but I think she's on mute. Okay, fine. Let us proceed with the next case. Okay, now this is a 19-year-old unmarried college girl presented with history of progressive growth of hair on her face and body for the last 9 months. On questioning, her periods have been occasionally delayed for the last couple of years. Menarche was at the age of 13 years. Obviously, this is a case of hirsutism of probably PCOS cause. What I want to ask the panelists, in your routine practice, do you follow the Ferryman-Galway score?
Yes, ma'am. We follow, madam. We usually grade. We already did one thesis now on a PCOS patient. We started comparing with estradiol and dosperinol, and before and after, we've seen there is a delay, there is decrease in the score. Usually the experiments are before and after, so there is a decrease in the score. So better to go for an fourth generation OCPs, which is having a less of angiogenic side effects and which will be effective in treating the hirsutism. So we have seen, madam,
it's a good thing that you're doing it, because otherwise, on an average, most people will not do it.
People don't do, madam.
Yes, I agree.
But
Yeah,
we
So
just
there are
see
some
the pattern, and if
to
it's
it.
in the lower tummy and chest, we all know it's a moderate to severe, madam.
Yeah.
Usually they don't have it in the chest and the tummy. So if they have it on that, you can, like, even if you're not seeing other parts, we know that it is moderate, more
Lower
than moderate
tummy,
or
medial
anything.
side of the thigh, these are
Yes.
the sides.
And
So,
sometimes in the
also
face,
because
it's very
this question
difficult.
I'm asking because there are a lot of ethnic differences,
Yes.
not only in different ethnicity, even in the same country. What you see in Chennai may not be the same picture that I see.
Yeah, I agree. I agree. Yeah,
Yeah.
same
Agree,
thing
madam.
happens
Agree.
in population here also.
Variations are there, racial variations. Yeah.
Yes.
Okay. So it's most practical way is to inform about ask about the frequency and method of hair removal.
Yes.
Of course.
Because many a times we just get we just get misleaded, madam. The face we see that, okay, no hirsutism, she looks very pretty. And then they come back and say, I'm undergoing laser therapy, like once a month I go for laser. I'm like, and then the dermatologist has sent me to you because the frequency of laser is too much for me. Then
Correct.
only, now it's an indirect way of coming and searching about hirsutism rather than finding any hair at all.
Right.
Come back and tell dermatologist is not able to treat me even with laser. So they said, go to a gynecologist, and then we get the cases now.
Okay. Sneha ma'am, this case, what are the other than PCOS, what we would suspect? Just she has come with the history of hirsutism and mild menstrual irregularities. So any other disorders we would like to rule out?
See, it is most probably what we need to rule out is the non-classical CH. That presents in a very typical classical way, like you think that it is PCOS, and when you investigate, it may turn out to be. And then, of course, the ovarian adrenal tumors. It may be just simple hyperthecosis, as you know, many of these adolescent girls, they have. But then they may not have menstrual irregularities simultaneously. So that is how you can differentiate. But then definitely hypothyroidism and hyperprolactinemia. These are the things you have to rule out. That definitely interferes with the ovulatory function and, of course, the cycle regularity.
Because in this patient, no, madam, you said the cycles are not that much irregular in this patient. So we don't have the two criteria to say that, yes, she is PCOS. So at least we should have an ultrasound for this patient to tell us it's PCOS or the other causes. And if your ultrasound pattern is not PCOS, definitely you should go and search about the other reasons for hirsutism rather than PCOS alone.
Okay. Ma'am, now recent guidelines also tells we have to take only free testosterone and total testosterone, and that too by liquid chromatography, assessment only. If this is normal, then only patient is having hyperandrogenism, then you go for the DHEAs and androstenedione levels to rule out the other causes of hirsutism.
Yes.
Right. So that is exactly what was the next question, that whether
okay.
we need to prove the hyperandrogenism, or is it sufficient to do it clinically and right away start the treatment? So Dr. Bhagya, would you like to make a comment? Dr. Bhagya Lakshmi, she's there. Bhagyashree.
Yes, ma'am. Same, ma'am. Means we have to do these biochemical investigations, free testosterone and free androgen index. And if it is raised, then we have to go for other investigations.
Okay. So a word of caution, if we are doing the investigation, then the hormonal treatment should be withdrawn, because usually if she is on some hormones which are suppressing her original hormones, we may not get the correct, values.
Yes.
Back to the contraceptive pills now, she's also having irregular menses and she's having hirsutism. So what are the drugs of choice which we would prefer, which can give her good cycle control as well as, address the hirsutism?
Actually,
Ma'am, I
initially
don't
we
know
can
just
give with the plain OC pills itself, madam. The patient has never been on a pill, and now it's the first time we are giving. Actually, that is what the endocrinologists they come up with. They say like, don't choose a OC pill with the androgenic effect. Like how, you need not have the anti-androgen effect cyproterone straight away. You can just give them the normal OC pills for them. And if it is never working, then you go and step up to the cyproterone acetate combination. So that is what the andrology, and if she's not on being any occipals, normal occipals itself will be useful. And actually, as per gynecologists, we all prefer to give her occipals rather than to give on anti-androgen drugs. We never go for that. We are not the fans of these fenestrite or other drugs, madam. We don't give that.
Okay, Dr. Chitra, if at all we need to give her anti-androgenic, what are the anti-androgenic drugs that we normally you prefer in your clinical practice?
No, madam, with the OCPs, we usually give drospirenol because even the guidelines states when you're giving OCPs, give some progesterone which is having an androgenic effect. So usually we give drospirenol, and sometimes if even with the cosmetic removal, the hair growth is more on, we'll put on low dose spironolactone. Low dose with the dermatology is put for spironolactone. That has gone to be quite effective, but we have to monitor her when you put on spironolactone. And I think finasteride we have not tried, madam. We have not put any finasteride.
Okay. Sneha, madam, what is your
she said
opinion
she's
about
using,
especially
madam,
cyproterone group of drugs? Cyproterone and other anti-androgens.
Ma'am,
Sneha,
Sneha ma'am is messaged. I have to leave for an emergency.
Okay. Dr. Bhagya, would you like to make a comment whether you are using cyproterone?
No, ma'am. Means we are not using cyproterone. Usually we use OC pills containing progestin as a drospirenone, and it gives best result.
Okay. So quickly, I'll go to the next case because already we are quite behind schedule.
Ma'am, I think only we three are there. You can
I
only
know.
tell us
So
this thing and
actually,
summarize.
I think we can go straight away to the take-home message. This is the next
better,
case
madam.
basically deals with the metabolic problems of PCOS. So now, instead of just going on about the case, I would directly want each of you to, give your message, take-home message for our delegates. What should we be doing for means in an overall management? Can you quickly, each of you, give us a comment? Dr. Priya?
Yes, ma'am. So lifestyle is what we are going to emphasize. So parent education is more important. Giving them about a low carb, high fiber, high protein diet is more important. Physical activity for a young child, I prefer to put them on a sport rather than gymming or any other activity. So some kind of sport and some activity is good for them. Even cycling or doing it at home or anything is fine. And I also motivate the family if the family is also obese. So they, as a group, if they do it, the consistency is more better. They sustain to the plan. I don't prefer to give metformin or inositol for adolescents, madam. If they're very pushy, I give. Otherwise, I don't give anything. Both of that. Ossipals, I do give.
Sure. Dr. Chitra?
Ma'am, this PCOS is it's from the adolescence, it go to menopause. So once a patient PCOS, we should have a regular follow-up. We should not treat the condition now. Even the patient's symptomology at high risk of PCOS, but we are not able to diagnose, it's better you treat her accordingly. You put us so that you prevent the metabolic syndrome like inomet hypertension, diabetic hypertension. And yes, a patient who is overweight, obese, I really treat her on metformin because this is known to have an decreases the risk of metabolic. So better to have a lifelong treatment and follow-up of this patient with you.
Dr. Bhagyashri, sorry.
In this adolescent PCOS, counseling is most important. Lifestyle modification, diet, exercise, rest, avoid stress, diet low carbohydrate, high protein, high fiber diet we have to recommend. Exercise at least 3 to 5 days per week, at least 30 minutes per day. We should advise exercise, rest, avoid stress, and if a patient is having symptoms and signs of hyperandrogenism, then we have to add oral contraceptive pills also, and we can add metformin also, as it is insulin sensitizing agent and it gives better result.
And one point which I like to make is like always you have to check for the sugar and resistance. I don't check insulin levels, but the sugar level and thyroid, prolactin, and yes, lipids also. Sometimes even it can be deranged in the child itself, like 14 years, 15 years.
follow-up of these patients is must
Correct. Very true.
to avoid further complications in their future life.
Right, right. So I would like to thank the panelists for
Ma'am, you need to keep this panel discussion again, because you had a beautiful nice discussion.
Yeah, very nice discussion. Very nice slides, madam. Lovely.
Again, ma'am, it will be very good to others.
Yeah,
And
that is true. So thank you so much. On behalf of the organizers, I would like to thank my panelists, and I'd like to thank the organizers, Dr. Supriya, Dr. Jairani, for making me part of this very interesting session. So over to you, Dr. Jairani, for your comments, and then we'll wind up.
Thank you so much. Thank you. That was a wonderful panel. Really, I just want to join as an expert, but you were all very much expert talking. I really thank Supriya and Niba Mahan. I think she gone for an emergency, I heard so.
Yes,
So my special thanks to Priya and Chitra and your panelists. Really, you made it very nice and very sweet and crisp. And very importantly, silently, you said about the importance of ultrasound, the diagnosis, what should be avoided, and about the treatment part, which is very important. And of course, nowadays, the fancy of patients coming straight to the clinic saying, "Oh, doc, I have PCOS."
Yeah.
They themselves will come with the diagnosis. Even this college girl, they will come and say, "Doctor, I have the PCOS." And inadvertently,
Madam,
I
not
was
only that, they say, I have taken treatment, now I want to do sonography to see if my PCOS is treated.
Cured. It's
So
cured.
that itself shows how much
Yeah.
less counseling was given.
Yeah, that's what.
We need to
No,
counsel
the
at
counseling.
the outset, that
No,
is
the,
not
more
something
than the more than the
go away.
counseling.
It
More
is
than the
there with
counseling, Supriya, the Google doctor gives a lot of information. And
Can I
all
ask one question, madam, if that
yeah,
is allowed?
please, sure,
Like, if
Priya.
at all, like, for example, if you see an ovarian volume of, say, 12 or 15, and now after lifestyle, if the ovarian volume comes down to 12 and it comes down by 3-4 ml. So the patient says, now my PCOS is better. Am I improving? So what is that? We have to tell her that, yes, your size is okay.
No, see, as it is, basically, you have to understand this is not a problem with the size of the ovary or with the follicular. It is one which are getting into immature stage. It is not maturing properly. That's what it is appearing in the ovaries as a PCOS. So you must say it is not the size or the number matters. It is your hormonal in your insulin resistance, which is mostly by your weight reduction. The size comes down not because of your size, your body size. If it comes down, automatically your ovulation will improve. That is
And
what
to begin with, it is a metabolic disorder. It is a disorder of insulin resistance, and that is never going to go away. You are born with it. You are born with those certain deficiencies. So those are not ever going to go away. So that is how that will keep them going for the weight part. That if you start gaining weight, again your problem will restart. So that will probably act as an impetus for them to continue good lifestyle. And one point very beautifully our panelists have brought out, that make the whole family part of that diet and exercise formula. Tell them first that is not diet, it is a lifestyle change. You have to change it for life. And entire family, I always tell the mothers, you cannot eat samosa and expect the girl to eat salad. You also eat salad. Don't bring samosa at home.
Correct.
True, ma'am. Very true.
So thank you so much, madam.
Thank you, Supriya, for your very interesting way you have put on this presentation. And really, I'm very thankful to one and all. A very special thanks. Yeah, very special thanks to our president, Dr. Jaideep Tank sir, and Secretary General Madhuri madam, and the committee chairperson, Dr. Supriya Jaiswal and Dr. Kiran Mai, and the TNFOG office bearers, President Madam Dr. Ramani Devi, Sampath Secretary, and the endocrinologist committee of MOGS, and a very special thanks to one and all, and a special thanks to the chief guest, Dr. Kiran sir, who has come and blessed us, and also the chair, guest of honors, Dr. Ameya, Dr. Raki, and Dr. Ramani madam, for giving all their wishes for this webinar success. And a very special thanks to the senior faculties, Dr. Kundan Ingel sir, Ganeshan, and IPS Radhika madam, and also Niba and Supriya for making all these things a very grand success. And a very special thanks to the chairpersons, the panelists, and all the other delegates who has joined with us. Thank you so much for
And Shield's platform, madam. Madam.
For this wonderful platform. A very special thanks to Shield and a special thanks to Shri Priya for coordinating it very nicely. Thank you one and all. And I think the Sahiti, you can get the recording of this, and so that it will be good for everyone who has missed the IPS part. We can make it into the committee to all the people to know about it. Thank you so much. Thank you.
Thank you, madam.
Thank you, ma'am.
Thank you, ma'am. Thank you.
Thank you.
So, Sahiti, are you there with us?
Yeah. Sahiti would have been there.
She's not.
Yeah, she's there. Sahiti Shield is there. Thank you.
Thank you, ma'am. Thank you. Thank you.
Bye.
Bye, ma'am. You can end the meeting, Sahiti.
Sahiti, you can end the meeting, Sahiti.